Okay, so it's time to start. Okay. Hi everyone, and so that distinguished guests and dear friend. My name is Ken Kato, National Cancer Center Hostel, and the host of this cancer forum. And good morning, and welcome to the third East Asia Esophageal Cancer Forum, so named ESO. So from this year, okay. And first of all, I would like to express the sincere gratitude for your time and contribution and the commitment for this meeting. I deeply appreciate it for joining the meeting and commitment for this forum every year. And this is a third time of the esophageal East Asian Esophageal Cancer Forum. This forum at the beginning at 3 years ago, to discuss about the esophageal carcinoma, mainly the squamous cell carcinoma, with Asian colleagues with us. So because as you know, the esophageal squamous cell carcinoma is predominantly exists in the Asian countries. And this is different situation between the Western countries. And it also in the ASCO ESMO, there's not so much the discussion is done, have been done with the Western the investigators. So we should discuss about the esophageal squamous cell carcinoma with Asian investigator ourselves. So the first meeting is discuss about immunotherapy and the other the therapy and their own research from each countries, and then we know each other first. And so last year, we discussed more further discussion about the immunotherapy. Including translational research, and then talking about oligometastasis. And we have done the pre-meeting and almost consensus meeting before the esophageal cancer forum last year first, and then this year. I gave a theme of this conference. Fully discuss about the oligometastatic diseases for further the clinical trials within the East Asian countries. Okay, we already discussed yesterday about the result of the almost Asian consensus, and the further today. So we would like to more details of that discussion about it, including about the further prospective clinical trial will be held in the Eastern Asia. So finally, I would like to thank all of them and all the participants and all the faculty and member and the speakers today. So I hope today, we erected the constructive discussion and leads to the further collaborative the prospective clinical trial. Okay, so let's start the cancer forum. So thank you so much. Okay. Okay, next. Please give us a comment from Professor Takeuchi. He's president of the Japan Esophageal Society.
Good morning, everyone. My name is Ray Takuchi from Hamamatsu University School of Medicine, Shizuoka, Japan. I'd like to say a few words of my greeting as opening remarks on behalf of the Japan Esophageal Society and the Jacob Esophageal Cancer Group. So it is my great pleasure and the privilege to welcome all of you to the third East Asia Esophageal Cancer Forum in Tsukiji, Japan. And also, especially, I'd like to express my sincere appreciation to all distinguished speakers and the chairperson from overseas, including Korea, China, and Taiwan. All members are, very important friends for a long time. Thank you very much. Thank you very much for joining us in spite of the very busy schedule. So, and also, I'd like to say thank you very much for Professor Ken Kato, who is Vice President of Japan Esophageal Society and Chair of International Affairs Committee of JES and JCOC. And also Professor Nomura from Kyoto University, who is the lead PI of the OMESC project, which he will present in detail. And also all staff in National Cancer Center Hospital and Kyoto University for preparing this this conference and organizing in detail. Thank you very much. So anyway, as Professor Ken Kato told us, esophageal squamous cell carcinoma is predominant in the Asian countries. And actually, we are leading the management of the ESCC as a leader of the world. So today we will focus on the oligometastasis of the ESCC, including the definition and diagnosis and treatment and the clinical trial design of the oligometastasis for ESCC patient. And also we will focus on the local therapy. Intervention of local therapy, such as surgery or radiotherapy, in the multimodal treatment of the ESCC, including oligometastasis in the era of the checkpoint inhibitors. So I sincerely expect fruitful and engaging discussion from this conference. And also, I'd like to, I very much look forward to the wonderful and the great achievement from discussion, which can lead the management of the ESCC as a leader of the world, and also improve the patient outcome in the future. So thank you very much again for joining us. Actually, in the outside today, it is very hot. Maybe it's supposed to be exceed 30 degrees outside. So I really expect hot discussion, compared to the outside in this room. So thank you very much again for your cooperation. I very much look forward to today's discussion. Thank you.
Okay, let's move to the session one. So could you come to the dear friend? My name.
So let's start session one. Good morning, every participant. So welcome to first session. My name is Hiroyuki Daiko from the National Cancer Center Hospital. This session will take chair by the Professor Daejong Kim from the Yonsei University. So the Shun Yamamoto from the National Cancer Center Hospital, and myself. So this forum is concentrated on oligometastasis treatment. So before going to the main session, we had better understanding initial standard treatment for each stages and recurrence for the metastatic condition. So this session consists of two topics. So in each topics, Japanese standard treatment will be presented firstly. Then, three other countries will introduce their standard treatment. So first, we have 4 experts in each country. So first speaker from the National Cancer Center Hospital, Dr. Koshiro Ishiyama. So shall we start your presentation?
Okay, thank you for your kind attention, kind introduction, Mr. Chairman, and good morning, everybody. I'm Ishiyama, National Cancer Center Hospital Esophageal Surgeons. And I would like to present a standard and alternative treatment for local stage ESCC in Japan. And this table summarizes current strategies. And for stage 1, the chemoradiotherapy or esophagectomy based on the JACOB trial is a standard treatment. And for the alternative options, the endoscopic submucosal resection followed by CRT is an option for the selected patient. And for stage 2 and 3, neoadjuvant triplet chemotherapy, DCF, followed by the esophagectomy represent the minimally invasive approach. And the course observation is a standard treatment for based on the 2 JACOB trials. And the patient refuse or unfit surgeries, the definitive chemoradiotherapy is alternative options. And for surgical treatment, main procedure is a transthoracic approaches, but the transcervical approach also available in the selected patient. And after the surgeries, adjuvant chemotherapy such as nivolumab is also available according to the recurrence risk. And for locally advanced T4 unresectable cases, its standard treatment is remaining the definitive chemoradiotherapy. But for the induction chemo-based, DCF-based therapies with conversion surgery is under the investigation now. And for the stage 1, the JACOB 0502 trial, it shows comparable survival surgery and the chemoradiotherapy for clinical stage 1. This is a non-randomized trial, prospective multicenter trials. And for JACOB 0508, it investigated the organ preservation strategies for the initially approaching the endoscopic resections followed by prophylactic chemoradiotherapy. And the 3-year OS around 90%, but this case it's indicated only a superficial ESCCs. And for clinical stage 2 and 3, JACOB 1109 trials, it shows superiority outcome for neo-DCF therapy compared to the neo-doublet CF or neo-CFRTs. And this is the JACOB 0909 trials for the stage 2 and 3 for the definitive chemoradiotherapy with salvage treatment. And the result shows 3-year OS around 70%. And this is organ preservation strategy. The esophagectomy free survival, 3-year free survival is around 63%. And for surgical approaches, JACOB trial shows compared with the thoracoscopic esophagectomy versus open esophagectomies. And thoracoscopic esophagectomy shows a non-inferiority compared to the open approach and reducing the blood loss, and the postoperative pneumonia is reducing for the thoracoscopic groups. And this figure shows the annual trend of the esophagectomy according to the Japanese Thoracic Surgery Association registries. And as you know, as you can show, the majority of the approach is minimally invasive esophagectomies, increasing year by year, and 90% is performing MIE. And for MIE procedures, the orange bar shows the transthoracic esophagectomy is slightly decreasing. On the other hand, the red bar shows the robot assist esophagectomy RE is rapidly increasing in the recent years. And purple bar shows the transcervical and transhiatal approaches to avoid the thoracic cavity and do not injure the chest walls. And this approach is very ideal, less invasive surgeries. But the number of the transcervical approach is around 20 cases in Japan annually. And after the surgeries, course of observation is a standard treatment, but the JCOB 2206 phase 3 trials is ongoing to evaluate the postoperative treatment, comparing the observation and adjuvant nivolumab based on the checkmate 577 and adjuvant S1 treatment, which S1, which is oral anti-cancer drugs. And right figure shows the phase 2 trial of the adjuvant S1 for 6 months after the surgery, neo-chemo or doublet CF therapies. And 3-year recurrence-free survivors are promising, and around 75%. And for the T4 unresectable for advanced cases, JCO group conducted the phase 2 trials. Initially approached the chemo selection with DCF therapy with conversion surgeries. And conversion surgery was performed 41%, and 3-year overall survival was promising the 46%. And based on these trials, the JCO 1510 phase 3 RCT trial is investigated compared to the definitive chemoradiotherapy versus induction DCF with conversion surgeries. And this study is already, recruitment is already completed and is in follow-up phase. Thank you for your attention.
Thank you. Good presentation. Next speaker is from China.
Okay. Hello, everyone. So this session we talk about the locally advanced treatment. So in China, we can say no matter for stage 1, 2, 3, or T4 resectable cases, mostly we follow the guidelines. But the guidelines divided from NCCN guidelines and GES guidelines. Even in China, we have the Chinese guidelines, but the Chinese guidelines, most the evidence-based articles from American, European, or Japanese colleagues. So no matter for which stage, all the standard and alternative treatment is very common in our daily life, as you say. So I want to talk one topic is very controversial, that is the T2N0 patients, because the T2N0 patients, the NCCN guideline, JES guideline, and the Chinese guideline are different. For example, T2N0 patients in JES guidelines, it is showed neoadjuvant combined surgery should be recommended, but NCCN guidelines divided to high risk and low risk patients, and upfront surgery is recommended. In China, of course, upfront surgery is recommended, and most of the surgeons are willing to do upfront surgery and adjuvant treatment or observation. So this is a very hot topic and need to do some research in the near future, I think. But because the other stages is very common sense, so I do not talk too more. So why early ESCC still matters? We know those reasons, because the most important, I think, it is the micrometastasis and lymph node metastasis. So T1A, T1B, or T2N0 patients, these early stages, we talk more. So T1A, we have the common sense that every patient in daily practice is underwent the ESD. They resected by the endoscopist. So but you know, for T1B patients, there is some controversial in it, especially for the invasive, for the lymph nodes, maybe, because the data showed the lymph node metastasis happened from 20% to 40% differently. So in China, the endoscopist is very aggressive. Yeah, very, very aggressive. So, for example, in our hospital, these 5 years, they performed the T1B cases gradually increasing. Yeah, and after resection, even there is not enough margin or depth, or the CT scan showed, wow, there's maybe some lymph nodes positive. They will find the radiologist. Yeah, to do the organ preservation, ESD combined with systematic therapy. And the patients are willing to choose, but there's no evidence for the T1B just to do the endoscopy combined with the CRT. So I think some clinical trials from JCOG showed there's comparative for ESD, CRT versus the surgery. But I think surgeons, most of the surgeons think surgery is the most prevalent and benefit for those patients, but it's controversial. For T2N0 is also, it is not a stable disease, I think. Yeah. So we can see from the data that 40 to 50% of the say T2N0 patients will upstaging after surgery. So that's why I think the Japanese colleagues, the guidelines show more better for neoadjuvant treatment after. But we can know some of the patients, it is the true N0, true T2, or even T3, but N0 patients. Those patients just perform the upfront surgery will live longer life. For example, my teacher in his era, they performed lots of patients like T2, T3, N0 patients. The patient can live very long. So this is the topic. So the East Asian approach and the Western approach is totally different for this resectable T2, N0 patients. So the upfront surgery, I think, is very important for comprehensive lymphadenectomy and accurate staging for these patients. But it's very controversial for neoadjuvant or upfront surgery till now, because I also talked to the teacher from American. They said you must divide the esophageal patients to different levels or different risk characteristics, and then to decide your treatment strategy. So I think the surgical quality is very still matters if you do the upfront surgery. In fact, is my or our current clinical approach for those patients, because I think those T2 and 0 patients divided to different risk factors. So high risk factors, of course, we should do the neoadjuvant treatment, but low risk factors, if we can identify upfront surgery, is useful for that. So I think the take-home message is very important for this is a gray zone for CT2 and 0. We should do the future collaborative research for that. And the biological research, even combined with the AI, is very important for those patients to divide to different levels to avoid over-treatment for neoadjuvant treatment for those patients. Thank you.
President, thank you very much for the very interesting topics. In my memory correctly, Professor Kim, so that you don't take a neoadjuvant treatment, even the T2 and 0.
Yeah, upfront surgery.
Oh,
yeah.
How about the T3 and 0?
Neoadjuvant therapy.
Oh, I see. Okay. So that after finishing all the presentation, we discuss. So next speaker from the please.
I represent the current standard arrangement of for local stage esophageal squamous cell cancer in Korea. And for stage 1, according to the 2020 guidelines by Korean Society of GI Endoscopy, EST is not recommended for SM invasion cases. So the standard first choice treatment is esophagectomy still in Korea. So the indication of EST is relatively narrower than in Japan. Yeah. So in terms of esophagectomy, nowadays the main mode of esophagectomy is robot-assisted transthoracic esophagectomy. But video-assisted or open esophagectomy could be reimbursed by our health insurance system. And when it comes to the extent of resection, surgical approaches vary among centers, ranging from Western style esophagectomy to Japanese style radical esophagectomy. And for the medically inoperable patient or in patient who refuse surgery, alternative therapy should be a definite concurrent chemoradiation, and preferred regimen is 5-FU plus DDP. And for stage 2 and 3 non-T4 disease, our standard treatment is a neoadjuvant chemoradiation therapy with a cross regimen followed by surgery. For patients who achieve the pathologic complete remission, we observe the patient at the outpatient clinic without any further treatment. And for the patient with the non-PCR cases, we treat them with adjuvant nivolumab. But that is not reimbursed. And alternative therapy, as for alternative therapy, neoadjuvant chemotherapy with a DCF regimen followed by surgery also could be performed. And for the definitive concurrent chemoradiation therapy, FP regimen is our preferred regimen. And T4 unresectable patient, definitive concurrent chemoradiation with FP regimen is our standard treatment. And in selected cases, especially nowadays, we are focusing on the lymph node metastasis to number 16, that is abdominal part lymph node patient. We can employ the neoadjuvant chemotherapy or neoadjuvant chemoradiation therapy followed by convergent surgery. And for the neoadjuvant chemotherapy, FP or DCF or pembrolizumab plus FP regimen could be used. And for the neoadjuvant chemoradiation therapy, also we use cross regimen.
Thank you very much. Next, from the time.
And good morning, everyone. And I am Yuan Zhen from National Taiwan University Hospital. And I will briefly introduce the practice at the highest volume esophageal cancer center in Taiwan, and which may reflect the current trends in Taiwan too. So this slide is an overview of the treatment strategies across the different stages of disease. And for early stage, including TIS and T1A, ESD, endoscopy local treatment, including ESD and EMR, is the standard approach now. And for longer or whole circumferential lesions, esophagectomy may be also considered. And for clinical T1B disease, the treatment strategy depends on the risk stratification. For low-risk patients, they undergo ESD, but for high-risk patients, esophagectomy is generally accepted. So when the final pathological report shows PT1B disease, additional chemoradiation is needed, or the patient just proceed directly to esophagectomy. So, and our institutional data show comparable cancer-specific survival between ESD and the esophagectomy patients. And for stage 2 and 3 resectable diseases, the standard treatment is preoperative chemoradiation followed by esophagectomy and the adjuvant nivolumab or other treatment for the indicated patients. And MIE, minimally invasive esophagectomy, has become a routine in many centers in Taiwan, including VATS and the RATS. And in my hospital, uniportal VATS and the RATS is our daily practice, and using Da Vinci system like XI and the SP system. And also the single port laparoscopic gastric tube embolization. And this is our operation room setting for URAMI, a uniportal robotic assisted MIE. Yeah, and for stage 4A unresectable diseases, an aggressive MDT will be arranged, and for aorta involvement, ANTIVA followed by a reassessment may allow some patients to receive subsequent definitive treatment, including surgery. And for trachea and or larynx involvement, or for very high level cervical esophageal cancer, and total pharyngeal laryngeal esophagectomy may be conducted in some patients if the tumor is located within 3 centimeters below manubrium. And these are the papers we published on TIVA use. And this picture shows how we do a local rotational skin flap to elongate the permanent tracheostomy. And this is quite useful if the tumor is located more distal. Yeah, and for T4B disease, for stage 4B disease, conversion surgery may provide some survival benefit if the metastatic lesions are locally controlled, and this is our research on the stage 4 esophageal cancer following chemoradiation and who received conversion surgery.
Oh, okay, thank you very much. Let's start the discussion. Please display the summary. This is a summary of the standard treatment for each stage in 4 countries. So regarding a stage 1, so standard treatment relatively similar, operation and the chemoradiation. So let me start with very difficult question for the expert. If you develop the stage 1 cancer ESCC, which treatment do you choose? Operation or the chemoradiation? Professor Kim?
If I got esophageal cancer?
Yeah, stage 1.
Very difficult question. To be honest with you, I prefer esophagus preserving treatment. So if there is no such risk factor such as SM invasion, and if there is no uptake on the PET-CT scan, yeah, maybe I need to meet our endoscopist first and try to undergo the diagnostic ESD. Yeah.
Firstly, ESD to assess the true depth of invasion.
Yeah. But if there is any clinical suspicion for lymph node metastasis, maybe I will consider also surgery, but prefer the surgery and then concurrent chemoradiation. Yeah, but if I got older than 70 years old or 75 years old, yeah, I prefer definitive concurrent chemoradiation. Yeah.
Okay. Next, Professor Allen.
Yeah, definitely for stage one, I will choose the more preserved strategy. Yeah, but the T1B is important because the real T1B, as I said, the accurate staging is very, very important for the oncologic evaluation. If it is a really local disease, of course, local treatment is enough, but it is a systematic or potential systematic, I think should combine the treatment is more better.
Thank you. Next, Dr. Ishiyama.
Thank you. I'm a surgeon, of course, so I would choose the surgeries. But it is important to the screening of the upper endoscopic annually to detect the very early stages to performing the endoscopic resections.
So you choose a surgery for the stage one, even you complain the stage one cancer.
T1B.
T1B. Who would you want to perform this operation?
If I was suffered from the T1B cancer at this time, I would ask my mentor.
You can choose China. Okay. It's hard to answer.
I would ask my mentor.
Computational Cancer Center.
So you will be a good surgeon. Yeah. Next, please.
For in our hospital, our surgeon also do ESD by themselves. So for stage one esophageal cancer, we also conduct the preservative strategy first. So and look for the final pathology to decide whether to do esophagectomy later or additional chemoradiation. Yes.
Thank you very much. So if you choose a surgery, so which procedure do you want to perform? It means transthoracic or transcervical?
Our routine is transthoracic, and transcervical is we haven't do that before, but we maybe in the future we can try it.
Thank you very much.
I have a question to Dr. Daiko. So in Japan, the concurrent chemoradiation therapy is equivalent option to surgery. So when you see the patient with clinical T1B patient, so you need to explain both options. So how about the changes of percentage? Who select surgery or who select chemoradiation? I heard that the number of patients who receive the chemoradiation therapy is increasing for stage 1B disease in Japan, right?
So after do you have any comment?
Oh, okay. Thank you for my thank you for my expression. And maybe in our hospital surgery division is very good surgery division. So very limited number, I think about 10 to 20%, I think. But maybe other patients receive surgery, I think. After 10 or 20% receive the definitive CRT, I think. Very limited, I think.
Professor Kim choose firstly ESD. So yes, it's a good idea, but there is a result of the ESD before the chemoradiation. Maybe Professor Muto, you are the principal investigator the ESD before the chemoradiation. Would you introduce the result of the clinical trial?
Thank you very much to give me the opportunity to speak the results of the JCO 0508. This study showed the excellent result, comparable result to the surgery, because ESD followed by chemotherapy is comparable to the surgery. The professional viewpoint of the surgeon, and they say that they explain the patient surgery is the standard treatment. But if the surgeon have esophageal cancer himself, maybe surgeon select less invasive treatment. Professor Kim said that diagnostic ESD is very important because clinical diagnosis is not perfect. And more than nearly half of the clinical SM shallow was finally diagnosed as mucosal cancer. And these patients can avoid the invasive treatment, surgery, or chemoradiotherapy. The ESD alone is enough treatment for such patient. Then if the deeper submucosal cancer is candidate for the surgery or chemotherapy, but shallow SM cancer potentially could be done the diagnostic ESD as a less invasive treatment.
Shall involve that SM1?
SM1, yes, SM1.
SM1. Okay, thank you very much. But why does this strategy doesn't so famous in Japan? Trend in Japan.
Yeah, I believe this strategy is popular, but it depends on the surgeon or medical oncologist and gastroenterologist. Their strategy depend on the each other.
Thank you very much. So, do you have any comment or question regarding stage 1? Okay. Next, going to the major cancer of the advanced cases. So the Professor Len give a big topics, T2 and 0. It's not indicated neoadjuvant treatment. Do you have any result for the upfront surgery for the T2 and 0?
Yeah, we analyzed the T2 and 0 and T3 and 0 patients. There's a retrospective analysis that showed if the P upfront surgery, after front surgery, the PT2 and 0 or PT3 and 0 patients, the survival is very close to those groups. So that's why I want to talk about those patients. If this is the real C T2 and 0 patients, maybe upfront surgery is better choice for that. But in China, most of the surgeons want to do the upfront surgery for T2 and 0, or even some of the T3 and 0 patients. So this is the real world practice in China. Yeah.
Professor Kim, do you have any result?
Not clinical T2 and 0, but PN0 cases. Yeah, so I studied about the result of the patient who underwent upfront surgery and who was diagnosed as PN0. That means PT1, T2, or T3N0. So once there was no lymph node involvement after 3-field dissection, recurrence rate was only 4%. Cancer death was only 1.7% in my series. So if there is actually no lymph node metastasis, upfront surgery is good. And as for clinical T2 and 0, I reported the instance of lymph node metastasis according to the status of preoperative clinical ctDNA do JAMA surgery this year. So if there is a detectable ctDNA, there is a high risk of lymph node metastasis in clinical T2N0 patients. So that may be our future viable option. And in other words, for patients with clinical T2N0, still I prefer the upfront surgery because there is a lower chance of lymph node metastasis as compared to the patient with the T3. And if there was actually PN0 patient, we can avoid unnecessary chemotherapy or chemoradiotherapy for those patients. That's my rationale. Yeah.
It's a very good idea. Do you have any idea for the ctDNA used before the surgery?
No, just the clinical trials. Yeah.
Do you know the result?
During our clinical trials of science clinical trials, we use the ctDNA in our single center. This year's ASCO meeting, we will present nearly 96 cases of ctDNA results. Excellent results for that. The baseline showed 98% of the patients has the ctDNA positive for locally advanced cases. So after 1 cycle, 2 cycle of systematic treatment, if it is positive, so the ctDNA decreasing and is very close to the PCR patients and MPR patients. Yes.
Thank you very much. Do you have any question regarding a T2N0? No? So Professor Matsuda, Keio University has already reported using a ctDNA for the ESCC. Yeah. Do you have any comment?
Oh, thank you. Thank you very much. Yeah, we are, although in the single institution, we developed our original ctDNA detection system. And then I think the accuracy is almost the same as the Dr. Len's one. The almost 95 or 98% we can detect the ctDNA before the treatment. And then almost half of the patient ctDNA was cleared after the neoadjuvant chemo. But it's not the same as the pathological CR. So even though patient still have the residual disease, the ctDNA was cleared before the surgery. But the prognostic impact of the preoperative ctDNA was remarkable. So in our system, the patient who did not have the ctDNA before surgery, most of those patients did not have the recurrence after surgery. So prognostic impact is better, is remarkable, but it's still immature to select the patient who has the pathological CR to detect a PCR before surgery. So we need to improve our system.
Well, thank you very much. So that after the neoadjuvant treatment, if the patient doesn't have ctDNA in the blood, even the ctDNA decreased level 0, so it's indicator for the surgery?
Yes, I think so. So we can say the patient that if your ctDNA became negative after neoadjuvant chemo, that's why once you receive the surgery, you can survive for long term. But the drawback of this system is that once we detect the ctDNA before surgery, we need to tell the patient that even though you undergo the surgery, you might have the recurrence. Yeah, but this is a still exploratory system, so we cannot tell the patient with the confidence, but in the future, we might do tell like that.
Thank you very much. Next, going to the neoadjuvant treatment. So in Taiwan, neoadjuvant chemoradiation is still standard treatment. But now, based on the result of the ESOPEC clinical trial, so the neoadjuvant chemo significantly improves the survival compared to the chemoradiation.
Yes.
So however, you follow the still cross regimen?
Our regimen is platinum and Taxol based for chemotherapy. Yeah.
Just only chemotherapy.
I'm not very clear about the neoadjuvant regimen. Maybe our colleagues next will introduce in more more thoroughly. Yes.
And
maybe in Taiwan, in Korea, maybe frequently use maybe cross regimen, I think, paclitaxel plus carboplatin, maybe I think. And I have one question. Maybe check 577 trial shows adjuvant nivolumab with non-PCR cases. So maybe in Korea is not reimbursed. Is that okay? And Taiwan is reimbursed in this adjuvant nivolumab therapy.
No.
No.
Yeah.
Okay. How about China?
No.
No. So maybe in clinical practice you do not use adjuvant nivolumab. Is that right?
In China, we do. We will discuss with the patients. Yeah, we can use the ICIs. Yeah, nivolumab or the other ICIs just based on the clinical trial of 577. Yeah.
Such as sintilimab or camrelizumab.
Yeah.
Professor, please give me a comment.
I probably can add some comments about the neoadjuvant in Taiwan. And I think the common practice of neoadjuvant therapy for stage 3 disease is chemoradiotherapy. Yes, and I think most sub-center will adopt the cross regimens, but still some still continue to do the cisplatin-5U combinations. And we know the very beautiful data of Jekyll 1109. So we know that neoadjuvant chemotherapy, intensified chemotherapy, should be another good choice for neoadjuvant therapy. But I think the popularity of that approach in Taiwan is start to increasing, but still the major practice is still chemorad.
Thank you very much. So regarding neoadjuvant immunochemotherapy, so the China is standard treatment?
No, not the real standard. I will talk some real status in China for neoadjuvant treatment, because the first Chinese esophageal cancer guideline just year 2019. That's the first Chinese guidelines. And mostly we follow the NCCN guidelines. So that's why this neoadjuvant CRT, the cross regimen, is the standard. But we make a questionnaire around the China. Only around the 10 hospitals ordinarily use the chemoradiotherapy. Ordinarily, most of the hospitals, they prefer to use the chemotherapy. Yeah, but the chemotherapy, they do not use the 5FU because more days. So mostly they use the platinum-based Taxol and those drugs. From the year 2020, because of immune therapy, so more than 10 or 20 phase 2 clinical trials for chemo combined immunostatin. So after the clinical trial of Escort-Neo, so the Chinese guidelines recommended it could be kind of a choice for neoadjuvant treatment based on the guidelines. So I think more than 90% of Chinese doctors, the hospitals, they will choose the chemoimmunotherapy for locally advanced cases, because from the phase 2 trial, phase 3 trial, at least the short-term study showed the PCR rate around 20% to 30% around, for chemoimmuno. But now, some high volume centers like us and Tanlijie and other hospitals, they are performing the chemoradiotherapy combined immunotherapy. But the chemoradiotherapy is not the cross regimen, it's modified regimen, more suitable for Asian patients. That's the status in China right now.
Which chemotherapy is the best partner for the IO treatment?
I think TC is more useful. Pardon? TC regimen, carboplatin. Yeah.
Dr. Yamamoto, you are organizer 1804E. which chemotherapy is the best partner?
Maybe based on the result of frontier study, maybe float plus pneumoma is very promising, I think. Float plus pneumoma. But about pathological CR was reported at 41%, very high level without RT. But float is now under investigation. So maybe I think the triplet chemotherapy is one option, I think.
Professor Renzo, thank you for the very interesting situation in the China. So you mentioned about the 90% of the institutions adapt for the chemotherapy and the neoadjuvant chemotherapy. And so as a result from the ESCOT-NEO trial, the standard of care are changing. But I remember the result of the ESCOT-NEO trial that is already published only with result with the pathological CR. So there's we don't know how the long-term result, the prolongation, the event-free survival, or the overall survival. So I understand that the each investigation thinking chemo immuno is better than the chemotherapy only. But why does the treatment guideline changing only with the result by the short time?
I understand your question. So in Chinese guideline also recommend A1, 2, 3. So the recommended one, the top level, of course, based on the cross trial CRT and the chemotherapy from the GCOG, and then the next level they recommend. That's a kind of expert consensus. Yeah.
So you mean that the weekly,
not the first level
recommended. So not the strong recommendation for that. Okay.
Yes.
Okay, I understand.
So how about the Korea?
So neoadjuvant chemoimmunotherapy is not allowed in Korea. We cannot use any IO agent before the operation, but only allowed in case of non-PCR after neoadjuvant concurrent chemoradiation. Yeah.
How about the Taiwan?
IO adjuvant is in some selected patients and is not covered by our insurance. So we have to discuss with the patient whether to add nivolumab or other IO regimen for their neoadjuvant treatment. Yes.
Dr. Tsushima, do you have any comment regarding IO treatment?
Yes. In Japan, IO neoadjuvant using is still investigational and not standard, but Dr. Yamamoto is now conducting new trial. So we will await the result.
Is there a possibility to conduct a clinical trial using IO for the receptor cancer?
Maybe in the future. Maybe IO combination neoadjuvant chemotherapy in addition to the adjuvant ICI is very promising, I think. But in Japan, very difficult about budget to conduct.
Okay. So unfortunately, there is no time to discuss. So the summary for the standard treatment for each stages, overall strategy is relatively similar. But now still surgery is mainstream, even the T4B cases. But next stage is maybe IO will be next mainstream. So thank you very much for participation.
Okay, let's move on to the next next session. This session is entitled Standard Management of Metastatic and Recurrent ESCC Patients. So maybe in this field is the main strategy is IO combination therapy. So 変わります？ Maybe Professor Lin is still here. Okay. At first, Professor Tsushima, please present in the Japanese current treatment strategy.
Yes. Good morning. I'm Dr. Tsushima, working for Shizuoka Cancer Center. I'd like to present Japanese status for metastatic esophageal cancer. This slide shows the summary of the standard treatment. And in Japan, marketing approval is practically meaning of reimbursement. So basically, the drugs are reimbursed. This is the treatment algorithm published in 2022. Strong recommended regimens are two kinds. One is cytotoxic chemotherapy plus one immune checkpoint inhibitor, and another is immune checkpoint inhibitor doublet, ipilimumab plus nivolumab. As cytotoxic chemotherapy, cisplatin plus fluorouracil is standard, and combined with one of three immune checkpoint inhibitors, pembrolizumab, nivolumab, or tislelizumab. And in Japan, no other immune checkpoint inhibitors are approved so far. Immune checkpoint inhibitors were approved based on the international clinical trials shown in this slide. I believe you all are familiar with the results. And in Japan, immune checkpoint inhibitors are reimbursed irrespective to PD-L1 expression status. As alternative regimens, substitute cisplatin to other platinum agent, oxaliplatin or nedaplatin. These drugs may be combined with immune checkpoint inhibitors, but the data on these regimens is limited. Let me move to the second or third line therapy. Basically, the regimens, including not previously used drugs, are selected. Paclitaxel is a standard if an immune checkpoint inhibitor was previously used. And immune checkpoint inhibitor monotherapy is selected if any immune checkpoint inhibitor was not previously used. And pembrolizumab is also used if the patient had a tumor with CPS 10 or higher or MSI high. And cytotoxic chemotherapy combination like cisplatin 5-FU are also selected if, for example, a patient had received ipilimumab plus nivolumab as the first line. And this is the rationale. And for about paclitaxel, Japanese randomized phase 2 trial showed benefit of weekly paclitaxel over tri-weekly docetaxel. And attraction 3 and rationale 3 or 2 studies showed the superiority of immune checkpoint inhibitor over cytotoxic chemotherapy as second-line treatment for patients who had not received immune checkpoint inhibitors. And recently, trastuzumab deruxtecan was approved for patients who had HER2 amplified esophageal cancer. And this drug is reimbursed only if HER2 amplification is assessed using cell-free DNA. And this is the base rationale of the trial. In Japanese HERALD trial included 12 esophageal cancer patients with HER2 amplification. And half of the patients responded to the trastuzumab deruxtecan irrespective to other gene mutations. And there's no other gene testing based treatment is not reimbursed. So this kind of patients are candidate for clinical trials. Thank you for your attention.
Thank you for your presentation to explain the Japan current status for the standard treatment of advanced esophageal squamous cell carcinoma. Maybe I think trastuzumab deruxtecan is a very promising agent for treatment, but maybe HER2 amplification is very limited. Maybe how about percentage?
I think it's less than 10%. Yes, very limited.
Yeah, very limited, I think. Okay, thank you for your presentation. Okay, next to the Professor Lenz. Please start your explanation.
For this part, it's hard for me as a surgeon. So I do not prepare the slides, but I want to say this is the first line, second line, and the treatment strategies I prepared. But most of the treatment strategy from the clinical trials, because in China it's very complicated. Not like Japan, you follow the JES guidelines. We follow different guidelines. NCCN, JES, and CACA or Cisco, that's Chinese guidelines, and some of ISMO. Yeah, but based on the Chinese guidelines, the medical insurance will cover. Yeah, for the NCCN guidelines, Japanese or European guidelines, it is a kind of explanation for the patient and to the insurance government. So most of the clinical trials, evidence-based clinical trials or guidelines, the Chinese doctors will learn and read and explain to the patients. So that's the status in China. Thank you.
Okay, thank you for a brief presentation. Okay, please. Next to the Korean status, please explain, Dr. Mihiho.
Yeah, this is the brief summary slide of current metastatic and recurrent ESC patient management. And currently, for first line, the 4 immunotherapy regimens are approved with various a little different the PD-L1 score. So, and recently it's changing rapidly. So I'd like to introduce the recent changes in Korea's situation. So I'm Minnie Hong, and before 2026, the only immunotherapy agent was reimbursed in Korea is a second-line T3 regimen. And for first line, the pembro chemo and nivo chemo was approved with some PD-L1 score. For example, for pembrolizumab, the CPS 10 or more was approved. That does not mean it's reimbursed. So pembro chemo and nivo EP was approved with already high the PD-L1 score, but was not reimbursed. So that means we need a PD-L1 test for the treatment of patients. So sometimes some patient does not have enough tissue, so we need rebiopsy and wait for the result. But then that sometimes took more than a week. So anyway, so sometimes with a very high burden patient, I used to start a chemo first, and then wait for the PD-L1 testing score and add the immunotherapy. That situation happened until last year, but we convinced our insurance, the government, that the best the data was shown in ESCC PD-L1 CPS was 10. So from this year, that the PD-L1 CPS 10 or more, the pembro plus chemo got a reimbursement. And Dr. Tsushima already introduced the Rational 306 study, and that in this study, even the PD-L1 less than 10 showed a better survival benefit than the chemo alone. So yeah, that the T-cell regimen plus chemo got approval, not reimbursement yet. So, but I heard that this summer maybe this regimen will get the reimbursement. So this is the current standard management of metastatic recurrent ESCC patient for second line. Yeah, the situation may be similar with the Japan, the docetaxel, paclitaxel, and sometimes we use immunotherapy in case of prior non-exposure to the immune checkpoint inhibitors. And in Korea also, I do NGS for identifying some hot amplification or EGFR or FGFR alternation, but all the agents are not that reimbursed. And I'd like to share some of my experience. That this is the article I published last year, and the first line ESC patient was collected from Asa Medical Center and our hospital, and totally 87 patients included. And there's some patients who had lower than CPS 10, but the most of patients get a pembro plus chemo, and the 30% of patients get nivo plus chemo. And the AE, the grade or 3 or more AE was reported in 50% cases, but the SAE was very low. It was 3%. And the efficacy data was quite similar with the KEYNOTE 590. The median PFS is about 6 months, median OS is 13 months. And we do some subgroup analysis that we identified some high risk features. That was the poor performance status, high baseline CRP, and low PD-L1 expression. And combined with these the features, we developed a progressive scoring model, and based on our scoring model, the survival curves was classified. There's some difference in survival curve. Yeah, thank you.
Thank you for your presentation on your Korean status and your research. Can I have a question? Okay. Maybe in your clinical practice, you check the PD-L1 CPS and PD-L1 TPS before the first line treatment. Is that right?
Until last year, I checked the CPS and TPS both, but from this year, only pembro is reimbursed, so that means we don't need TPS score. Okay. So nowadays I prescribe PD-L1 2-3 PAMDS for TPS scoring.
Okay. Yeah. So in your clinical practice, only pembro plus doublet chemo is used in.
Sometimes in patient with PD-L1 low, PD-L1 0%, the T-cell regimen or plus chemo, patient can receive, but out of his pocket.
Okay, thank you. Okay, thank you for presentation. Okay, the last is Taiwan doctors. Okay, please your presentation.
Thank you. My name is Dr. Vincent Zhuang from NTU Cancer Center. It's nice to be here. Let me briefly introduce some basic background numbers before reaching metastatic recurrent regimen standard of care in Taiwan. So esophageal cancer in Taiwan, this is the statistical trend. As you can see, in the past 30 years, the case number increased from 700 30 years ago to around 3,000 cases per year. And most of the cases are male squamous cell carcinoma. So this is the our epidemiology statistical numbers for you. And for improving cancer care in Taiwan, in the past 20 years, we have some laws to regulate the physician, like Cancer Control Act, Cancer Care Quality, accreditation for cancer care hospital. So we try to use the multidisciplinary team care in our daily routine, and we have to develop every institutional treatment guideline for quality control. So this is our hospital guideline, and we should review year by year based on the new clinical trial results. So for the accreditation. And specifically in Taiwan, we have the National Health Insurance Program since 1995. This is a single payer mandatory insurance system cover all Taiwanese population. And for approval, the drug approval is by Taiwan FDA, but drug approved by Taiwan FDA does not equal to reimbursement by our health insurance. So if the drug without health insurance reimbursement, the patient should pay 100% by him or herself. We don't have the co-payment system now. So for the first-line systemic therapy, esophageal cancer, ESCC in Taiwan, you can see there are some Taiwan FDA-approved option, but regarding the reimbursement, since this year, February, reimburse nivolumab combined with chemotherapy for first-line esophageal squamous cell carcinoma, and conditionally PD-L1 TC greater than 1% using the 28-A DACO immunochemical history antibody. This is the first line. So you can see the table. The first line standard of care using nivolumab plus 5-FU cisplatin or oxaliplatin for PD-L1 TC greater than 1%. And you can use some alternative like nivo-EP, pembro plus chemotherapy, cisplatin plus paclitaxel plus 5-FU. We call it TP high dose FL. We have some studies before. So doctor want to use all kinds of these options is okay. And fortunately, in NTU hospital, we have some clinical study like IDSD combination first line study. So we will tell all the possibility option to our patients to make decision to use the health insurance coverage, alternative, or clinical trial. This is the first line scenario. And regarding second line, you can see there are some options, right? But only nivolumab is reimbursed in 2024 April, since 2024 April, with the PD-L1 TC greater than 1%. So let's see the table. So if the patient doesn't have the immunotherapy before, the nivolumab is reimbursed. But we can tell patient you can use pembro, TCA, that is okay, and some chemotherapy, but some chemotherapy doesn't reimburse in our system, you can see. So it is really hard to say the details to the patient. So we have to make decision with patient, but we always decided in the second line setting. And we also have the IDSD second line study in NTU hospital, so we will discuss with the patient. And regarding the biomarker, our reimbursement system require every patient to check PD-L1 reimburse for nivolumab once and during the disease journey. So if you want to do second, third PD-L1 IGC study, patients should pay by themselves. And the NGS doesn't cover the esophageal squamous cell carcinoma.
So in Taiwan, TFD approved defines what can be described, but reimbursement defines what is practically standard. That is the scenario. Thank you.
Okay, thank you for your presentation in Taiwan. I have one question. Why is only nivolumab was reimbursed?
I think we should ask MSD in Taiwan.
Okay, thank you.
The situation quite different from Korea. Korea has only reimbursement for pamphlet only.
Yeah, I think it's very interesting.
Okay, so thank you for your presentation. Okay, in maybe next to the in summary slide, please show the. Okay, I will discuss about the maybe from the first line topics. Maybe all country can use immune checkpoint inhibitor plus doublet chemotherapy is maybe I think the standard. But in the MCC guidelines shows baseline chemotherapy, cytotoxic chemotherapy recommended the oxaliplatin based regimen. So some clinical trials such as LEAP-114 or KeyMaker-060 study was defined the FOLFOX regimen is one of the standard treatment. How about FOLFOX based regimen in each country? Dr. Tsushima.
Yes.
FOLFOX plus ICM.
Yes. As you know, in Japan, oxaliplatin is not approved, but not approved for esophageal cancer. So the data is very limited in Japan. So FOLFOX is promising, and I think it's a maybe better regimen than cisplatin-based regimen, but collecting the data of FOLFOX in Japan is a little bit difficult. And as you know, we conducted the observational study, and it will used for future evidence.
Okay, thank you for your explanation. Maybe in Japan, only FOLFOX combines nivolumab is can we use in clinical in our clinical practice. But pembro or tisreg we can't use in clinical practice. Maybe FOLFOX nivolumab is I think one is good option. I think in the future.
Yes, and as you know, we can use FOLFOX for gastric cancer. So. Yes.
Okay. Please comment from Professor Hong.
Yeah, in Korea, the FOLFOX does not have approval in ESCC, so we cannot use. But in a clinical trial, I have many experience using FOLFOX in ESCC. Yeah.
How about your experience in the clinical trial cases?
Actually, the short duration regimen than the 5-cisplatin. 5-cisplatin requires 5 or 6 day, 4 or 5 day infusion, but the FOLFOX is just 2 days, so it's much more convenient for the patient and the hospital.
Okay, thank you. Maybe FOLFOX is less toxic compared to cisplatin, so I think FOLFOX is a good option. I think. How about Dr. Chang?
In fact, I'm not. I don't know the other centers, but in our center, we use a lot of FOLFOX, and we have experiences for that, especially for the second line therapy or recurrence patients. Because in our MDT team, our oncologist is very willing to use FOLFOX combined some treatment or not FOLFOX, or use the new treatment like ADC drugs to treat the recurrence or very hard treated patients. So that is the status in our hospital. Yeah.
Okay, thank you. How about in Taiwan? Maybe in Taiwan is used in the first line is oxaliplatin based is some option?
Yeah, physician can choose either cisplatin or oxaliplatin. But in my experience or NTU hospital, we use cisplatin more, and we will modify the cisplatin dose schedule to make split to day 1 and day 8, or to titrate the cisplatin dosage gradually to mitigate the toxicity, to make patient can get cisplatin more tolerable, because oxaliplatin also have some neurological complications. So we can, not in clinical trial setting, in real world or daily practice, we'll split the cisplatin or titrate the cisplatin dose gradually. Thank you.
Okay, thank you. Maybe in that cases, in the first day and eighth day.
Yeah. Split the cisplatin and 5U to day 1 and day 8. Modify schedule.
40 milligram per body. Per square.
Yeah.
Okay, thank you. Maybe first line observation, I think Professor Kato.
Thank you for the very important discussion. So I would like to ask Professor Leng and Professor Hong about the selection of the immune checkpoint inhibitors. So in China, so many ICIs in China. So camrelizumab, sintilimab, and toripalimab. So how do you choose the ICIs when you maybe your medical oncologist team treated for the first line chemotherapy, and then in China there is no limitation for according to the PD-L1 status or not?
Okay, that's a good question. It's a kind of a question like from a marketing manager. This is the same question I answered to the marketing manager. Yeah. Most important is the safety and efficacy for the treatment. At the beginning, as a young surgeon, of course, at the beginning, as a surgeon, we use the ICI. We're worrying about the safety, because from oncologists, they use the ICI for the first line, second line patients. The PS status is not very good. And they told us the safety is not good. There is a lot of complications for ICI. We're worrying about that. But after use for the surgical patients, we think, it's a safety. It's controllable, no matter for chemo, immuno, or CRT immuno. It is very easy or safety to manage those patients. So after that, we know no matter for the nivolumab or Keytruda or domestic drugs, we use daily practice or clinical trials. We see the same, nearly the same. It's comparable for the safety and the efficacy, especially for the patients. So how to choose those too many drugs? I think important it is for the support for the team establishment,
from the
academic
pharmaceutical company.
Yeah, academic support. If the companies has an academic pursuing and very good at academic, I think the clinical trials and the data and those things are better for your team's choice. But if they just for commercial, I don't think that's a good choice for that. So that in our team, we will choose the drug. It is safety, efficacy, and economic is also very important choice.
Yeah, I think that's the efficacy and the safety data of each PD-1 and the PD-L1 antibody is the same and similar across the Chinese drug and the Nivo.
Similar. We just say similar, but in our mind, there's some different for the complications. I think.
Nivo and the Pembro, also the Nivo and the Pembro is higher than the Chinese ICIs inside in China, right? It is right.
Yes.
The price.
Yes, it's very high. Yeah, at the beginning it's 10 times of the prices. But now there is some policies to decrease the price. Yes.
Okay, thank you so much. I have a question ask for Dr. Hong. And so you mentioned that the tislelizumab will be approved for the first-line chemotherapy, regardless of the PD-L1 status, right? If so, how do you choose the ICI for the first-line chemotherapy?
That is very simple because our health insurance system defines the clinical standard like Taiwan. So for the patient with PD-L1 CPS 10 or more, then only pembro is reimbursed. So I use pembro plus chemo, and the PD-L1 CPS less than 10. Then the only agent we can use is tislelizumab. So that is tislelizumab. And Nivo has no role in our in Korea.
No role. Okay. but you can use the tisle even for the patient CPS more than 10 patients.
But the price difference is quite big. It's 20 times expensive than the.
Oh, really?
Yeah.
Oh, okay.
So on the reimbursement, the patient pay just 5% of the drug price. So very cheap. Yeah.
So that depend on you selected the tisle, CPS less than 10, and the patient with a CPS more than 10% is a pembro you choose. Okay. Thank you very much.
Can I also pose a question to Dr. Hong?
Professor Hong.
That's about the assays of PD-L1 expressions. We know that we have several antibodies, 22C3, 28-A, and also SP263. So when you say that you are going to have the tislelizumab approved for the first-line settings for PD-L1 positive cases, so do your regulatory demands specific PD-L1 assays?
Yeah. In most cases, the government specified the PD-L1 assay. So in lung cancer, SP265, 263, yeah, and the pembro in ESCC, the specific antibody and testing is PD-L1 223 PAMDX, and for tislelizumab maybe the same to the other agent like SP263. The government specifies the.
So for esophageal cancer patients, you need to check both 22C3 as well as the 263 TPS.
Yeah. Same in Korea. Same in our center.
Okay.
Any other questions? Okay, Professor Matsuda, please.
Yes, I'd like to, considering the discussion in the later session, I'd like to ask about the definition of the metastatic lymph node in the stage 4. In Japan, we consider supraclavicular lymph node is not M1, but lymph nodes located on the left side of descending aorta, that is M1 disease. And para-aortic is M1, and or upper cervical lymph nodes, such as the lymph nodes surrounding the upper cervical side, that is M1. So I like to ask which metastatic lymph nodes is defined as M1 disease in the Korea, Taiwan, and China.
Please comment.
Okay, as a surgeon, we for the TM stage, we follow the AGCC. Of course, the 104 is when we write the record, that is M1A. But in our guidelines also said that is a kind of can be treated, local resection treated M1A patients. So 104 and the other lymph nodes that you said, if it is evaluated to be locally can be resected, we will do like a neoadjuvant and then surgery.
So what about the pretracheal pretracheal lymph node, you can technically resect because you are
not ordinarily resect because it is like a lung cancer station 2 and station 4, not ordinarily resected. But 106 pre is if the lymph nodes metastasis happen there is more aggressive. It is a kind of alter regional. Is I think.
Okay, thank you. What about in Taiwan and Korea?
In Taiwan, as in NTU Hospital, we have twice daily multidisciplinary team discussion. No. Twice, bi-weekly, bi-weekly. And we have the cancer registry. So we follow the AJCC 8 edition for every case for cancer registry, but for management, case by case. As you mentioned that if the patient have metastatic lymph node only, you can intensify systemic therapy first, then followed by response, or we can use the neoadjuvant chemoradiotherapy followed by surgery, because some neck lymph node, Professor Lee can still combine with our ENT surgeon to resect all the lymph node. But some lymph node below ciliary trunk, from neck to cilia, very extensive lymph node, we will try to intensify systemic therapy or try to enroll the patient into clinical trial first. We call it still the metastatic disease. Thank you.
Yeah, similar to China, the supraclavicular neck lymph node is considered as resectable M1. So I usually consult with the Dr. Dae-Jun Kim, and he many times he wants neoadjuvant, some kind of neoadjuvant treatment.
Number 104 and number 106 pre in upper thoracic esophageal cancer, they are regarded as a regional lymph node. So this is not a metastatic setting. And for me, if there is metastasis to 100TR or number 16A or 16B or 106 pre, I think that is a treatable M1. But for axillary lymph node or lymph node in other parts, I think that is true metastatic setting. So our neoadjuvant chemoradiotherapy followed by convergent surgery should be confined to those of the treatable M1 lymph node disease.
Thank you. So if you have if you had a patient with a primary tumor and then single 106 pre lymph node, it is considered as a regional kind of the local disease, not a indication of the immunochemotherapy.
Currently we employ the neoadjuvant chemoradiotherapy followed by surgery.
Thank you. Thank you very much.
So this is controversial from a different country, I think, for 106 pre. That Professor Kim said is original. And what about your opinion?
In Japan, in general, Dr. Daiko can technically resect it. But usually we are considering it
I think you can do it. It's a very easy area for
right. So oncologically unresectable in Japan. That is Japanese that is Japanese consensus, I think.
Okay.
I think now TN classification from the JS, AJCC, so that it is determined by the very old data comes from the upfront surgery. Now is a never adjuvant era. So we have had already reported even the M1 lymph node disease, including 114 the paraortic and 116 pre, it's considered the good oncological outcome.
So it was shown to have the good oncological outcome, but in the oligo discussion, still we are considering that is M1. So we need to determine whether that is considered as an oligometastatic, that is M1, or that is regional.
Yeah, because in our data, I think 106 pre is very rare to happen metastasis for lymph nodes, the regions. But if it happened, it means most of the patients has N3 patients.
So in our department, so M1 lymph node classified to part of the resectable M1 lymph node and the unresectable M1 lymph node.
so National Cancer Center, the 106 pre, and then the 16A2 is kind of resectable M1.
Yes.
Okay, thank you. I understand.
Okay, maybe last discussion is very hot for me. Okay, so very time is very limited. I would like to close this session. Thank you for your presentation and thank you, Chairperson. Thank you.
Okay, let us move on to the session 2 named OMSC Asia Consensus Meeting 1. My name is Hirota Kuchi from Hamamatsu University. So it is my great pleasure to chair this session with Professor Shi-Han Shu from National Taiwan University. We are very sorry Professor Tang is not here today, but we will proceed this session. So initially, we will ask Professor Monomura from Kyoto University, who is a PI of the OMSC project. So he will talk about the results of OMSC 1 to OMSC 4 so far. And after that, we will discuss the, OMSC project currently proceeding and as a, step of the clinical trial. So every panelist can have, hand fun, agree and disagree. You can use if you are very hot. Okay, I would expect very unique and interesting opinion in the discussion session. So initially, I'd like to ask Professor Nomura to have your presentation. So please.
Yep. Thank you for your this opportunity, and it is a great honor to this presentation at the East Asia Esophageal Cancer Forum. I represent the OMSC project. So this is my disclosure. Our outline of OMSC project. So that's epidemiology of esophageal cancer. Esophageal cancer is categorized into adenocarcinoma and squamous cell carcinoma. But our squamous cell carcinoma incidence is the highest in our area. Our aggressive local strategy for squamous cell carcinoma provide unique insight into the management of oligometastatic disease. So the OMEC, the oligometastatic esophagogastric cancer consensus, it's a great achievement by European key opinion leaders. That their specialty is undertreated adenocarcinoma. So no distinction was made between adenocarcinoma and the squamous cell carcinoma. Given this difference, does the adenocarcinoma-based strategy and consensus apply to squamous cell carcinoma? And very important trial, so ESO Shanghai 13 trial. This is very good data. So survival improved with the addition of local treatments. But you can see this strict criteria, so that eligible patient had a controlled primary tumor for over 3 months without progression after treatments. And the majority of eligible patients had a very limited disease that primarily 1 or 2 regions in a single organ. This suggests that oligometastatic strategy for squamous cell carcinoma is different from adenocarcinoma. So this difference, so we conducted the OMSC project. So you can see this slide and the figure. We conducted this OMSC project consists of 5 phases studies. OMSC 1 is systematic review and meta-analysis. OMSK2 is a case discussion of real-life clinical cases. OMSK3 is a multi-center retrospective study. And based of this 1, 2, 3, the data, conducted the OMSK4 Delphi consensus study. So I will present the OMSK 1, 2, 3, 4, and this results of these data. Firstly, I present the results of OMSK 1. This is a systematic review and meta-analysis. So we search on the 4 databases, PubMed and MBase, Central, and Clinical Trial Governments. Of this, 3,844 records were screened, and 34 study or study protocol is included. This 34 study and the protocol were included. This is 23 retrospective study and 4 prospective trial included in ESO Shanghai, and 7 ongoing trial protocol. OMSK agreements categorized as under 50% is absent or poor, and 50 to 75% is fair, or over 75% is strong. So that's the results of this OMSK1 is synchronous OMSK is 1 organ with up to 3 metastatic lesion. And the metachronous OMSK is 1 organ with 1 or 2 metastatic lesion. But you consider this different or this synchronous is more metastatic lesion, but this definition is likely influenced by selection bias in available literature. But the next meta-analysis results that 10 study compares the OS after local therapy plus systemic therapy with systemic therapy alone for oligometastatic squamous cell carcinoma. Local treatment for OMSK was associated with improved OS compared with systemic therapy alone. The next show the result of OMSK2. This is a case discussion study. Yeah, totally 58 institutions participate. This table shows the characteristic of the expert participating in multidisciplinary teams. So the results. Yeah, that's 15 patients cases. So experts checked this is oligometastatic disease or not, and what treatment is recommended. That's what treatment duration, and I asked this every cases. So the results, 2 cases is oligometastatic disease. Only 2 cases. This is I selected different or very difficult to judge cases I selected. I'm very sorry. And next, bilaterality is all cases show the no consensus and under the 50% of agreement rate. Next, the diagnosis is all patients receive the CT, and additional tests is PET scan was frequently recommended as a further diagnosis evaluation. And next was MRI for liver lesion. The treatment is this oligometastatic disease. The recommended treatment at initial is systemic therapy. Almost teams so recommended this systemic therapy. And minimum duration of systemic therapy requires 3 or 4 months. Initially oligometastatic disease diagnosis, but remained after oligometastatic disease after systemic therapy at re-staging. The next show the results of OMS3. That's a retrospective study in Japanese patients. Now we reviewed the retrospective study. The patients enrolled the metastatic esophageal squamous patient with under 5 distant metastatic lesion. The PFS and the OS were compared between the systemic alone and the systemic plus local therapy and upfront local therapy alone. Yeah, the results of these data. So this data, the survival data, were compared between synchronous versus metachronous patients who were treated with systemic therapy alone. There were no significant difference between synchronous and metachronous disease. And next is the survival outcome by number of organ metastasis patient. This data so more number of the organ metastasis is worsening, but yeah, then and then survival data by number of lesion patients with who were treated with systemic therapy alone. So you can see this data. There is no difference with between 1, 2, 3 lesion. Yeah. Next, compare the treatment strategy. So the PFS and OS, you can see the systemic plus local therapy is the most longest survival data in this treatment group. But this patient, the selection, there are selection bias, but we used analysis using propensity score matching. So the patients selected the systemic therapy and the systemic therapy plus local therapy group. The data that show this slide. So the systemic plus local therapy is longer OS and PFS compared with systemic therapy alone. So that's it. Next, continue. Okay, so the next show the result of almost 4. This is a Delphi consensus study. So the participating the 77 doctors this study. So half of the doctor of the surgical oncologist and almost the East Asian doctor. And this Delphi consensus methodology was conducted in 3 online questionnaire rounds. This questionnaire statement was derived from preliminary study OMESC 1, 2, and 3. So the expert evaluated the statement using a 9-point Likert scale or selected from multiple choice option for lesion limits. The response were evaluated based on the following 3 categories: 1, 2, 3 points as disagree, 4, 5, 6 as neutral, and 7, 8, 9 as agree. Level of agreement is shown here. The 0 to 49% is poor agreements, and 50 to 74% is fair agreement, and over 75% is consensus. So the established consensus of OMESC4 or this definition, the diagnosis and the treatments. The initial definition showed hilar axially or abdominal para-aortic or pelvic, and inguinal lymph nodes is distant metastatic lymph nodes. And the number of involved organ is limited to 1 distant organ. But if the primary tumor or lesional lymph nodes are present, limited to 1 lesion in 1 organ. So the what I showed the table. This is organ specific and the timing criteria. So if the patients have a lung metastasis and synchronous disease, so our consensus is a unilateral 1 lesion. And if the patient lung metastatic metachronous disease, so the unilateral or 2 lesions, upper 2 lesion. And next, the diagnosis is additional imaging based on the OMESC2. So we think the question this OMESC4, the PET and liver specific MRI were recommended. And biopsy was not mandatory but preferred this data. And ICI should be incorporated whenever feasible. And at this systemic therapy duration is at least 3 months. And the decision-making treatments must be determined by multidisciplinary teams. So next is a question.
Okay. Before this discussion, I want to ask Professor Nomura about very, essential primitive issues, but very important. In your opinion, what is the, image of the oligometastasis? I mean, oligometastasis, for example, this is my opinion, oligometastasis, it's kind of the systemic disease, but can be controlled by local therapy for curative intent.
Yes.
Yeah. What about the other opinions, such as prolongation of the better QOL after surgery, after local therapy, or something like that? Can I ask you first?
I try to this I hope and patients hope the cure this disease. So the that's oligometastatic disease define the benefits of local treatments, but our patients want the cure. But this patient, the oligometastatic, but this is a distant metastatic lesion. But I think there are I explained your palliative chemotherapy treated this regimen, or which recommended which regimen choice. But I want to cure them.
Do you all agree with that? Agree? Disagree? Raise your hand. Okay. Oh, disagree. Yes. Professor Xu? Yes. Do you have any opinion?
Thank you. Thank you very much, Dr. Moro, for the wonderful works on OMAS studies. I think there's tremendous works over the past 2 years, and we are really happy to know that the program has progressed from OMAS 4 and now is aiming for OMAS 5. And so I think I also agree with that we should start with the definition of oligometastasis. And so I agree with the definition proposed by Dr. Takeuchi, that that's indeed a disease of metastasis, but those metastatic lesions can be treated by curative intent local regional therapies. And so I think it's good for us to start with the definitions and let us to start from the same line to have the further discussions.
Okay. Any other comments from the panelists? Completely agree with that. Okay, thank you very much. So move on to, so you can see this slide. Okay. Okay, I understand. Okay, so you can continue.
So first question, so for the definition of oligometastatic disease, so should the supraclavicular lymph nodes number 1 or 4 be classed as distant metastasis? Yeah, distant metastasis, you chose the distant metastasis is agree, but not distant, this is local is disagree.
Okay, that's very good. Yes. When you only agreed. Yes. Do you have any question or comments or something?
I agree with it is distant metastasis. Yeah, because if this is for international things, you must follow international rules.
Yeah.
So no matter the AJCC and the JES current TM stage, 104, of course, it is M1. So we all know that is treated, can be resected locally, but maybe Western doctors, they cannot understand. So at the literature, I think, yeah, it can be the distant metastasis. Yes, that's my point.
You're a global doctor. Very good. What about, other doctors, such as Professor Lee? Do you have any comments?
I agree, but as for some degree extent, I agree with Professor Lang's point of view, because the global view about 105 should be classified as a distant metastasis. But we should pay attention that the Western pattern and the Eastern pattern is somewhat different. From the point of view, it is the adenocarcinoma in the lower third, in the supraclavicular metastasis. I think there is no question. But in our real world practice in in the East Asia, squamous cell carcinoma is very frequent to metastasis over there, and the three-field lymphodissection is over here. So, if we want to treat this, because it's very regional specified treatment option, we will have to reflect the real-world practice. Otherwise, when you the Western standard, you are somewhat misleading and somewhat interpretation in the final result.
Okay, very good comment. What about South Korea, Professor Kim?
Yeah, it's regional. regional. I studied my patient with the supraclavicular lymph node metastasis last year and reported to our society meeting. And in patients with the supraclavicular lymph node metastasis, also there are much higher number of metastases, not in the mediastinum, but also the abdomen. And also those patients expresses more aggressive pathological features such as lymphovascular invasion or peritoneal invasion. So in my opinion, supraclavicular lymph node metastasis means advanced disease with higher tumor burden. And the location itself is not so important. For example, in patients with upper thoracic esophageal cancer with supraclavicular lymph node metastasis, it could be cured after surgery or neoadjuvant chemotherapy followed by surgery. So that's why I think that supraclavicular lymph node metastasis should be regarded as regional. And other thing is that NCCN guidelines, as you know, recommend at least 15 lymph nodes at the time of esophagectomy. But in real-world data in the US, the number of hospitals which retrieved more than 15 lymph nodes is only 8%. Only 8%. Their retrieved number is less than 10 or 8 or something like that. So if they find the supraclavicular lymph node metastasis, that means there must be much more higher lymph node metastasis. So this must be the very advanced disease. Yeah. So I think the location itself is not a matter for me. Yeah.
Okay, Dr. Matsuda, do you have any additional comments?
Yes, I agree with the previous comments. Even though supraclavicular lymph node metastasis is indicating that massive tumor burden, and then that is located in the kind of intersection between the M1 and local, but at least 104 can be classified as a distant, the regional metastasis in this occasion.
Okay, thank you very much. So actually, we need to emphasize, this agreement about supraclavicular lymph nodes, because in terms of the difference between the squamous and the adenocarcinoma in the world. Okay, next question.
Yeah, next. Therefore, the definition of oligometastasis, should cervical lymph nodes, so upper the supraclavicular, this cervical lymph nodes was classified as distant metastasis or not?
Cervical lymph nodes stands for the 102 or something, I think. Yes. So, could you answer? Agree? Disagree? Or something? Oh. Okay. So, middle.
Yeah.
Okay. You can change rapidly. Okay, Professor Kim.
I need to clarify the definition of cervical lymph node here, because 101 is a regional lymph node, but 100 TR or 102 mid should be regarded as distant, right? So that means 102 is cervical lymph node.
It's 102. He is indicating. He's saying the 102.
Yeah, I think so. Yes.
Not 101.
Not 101. Any comment from Professor Shu?
No, it's my personal opinions that lymph nodes above the levels of supraclavicular and middle higher upper thoracic region, neck cervical regions, I would treat them as a metastatic disease.
Any different comment? Okay. Okay, next.
Yeah, our data, so MSK4, this is not reached the consensus, but this is these data, so fair agreements rate, the supraclavicular is more locally, but not consensus, but the cervical lymph nodes is distance. This is fair agreements. So
next. Okay.
Yes. For the definition of oligometastasis, should mediastinal lymph nodes outside the paraesophageal lymph nodes. So, example, the anterior mediastinal lymph nodes or pretracheal lymph nodes, so be classified as distant metastasis. This is a question by the previously Dr. Matsuda.
Do we need to separate anterior mediastinal and the pretracheal in these questions, or we can think together?
Okay, we will combine together. Okay. So, could you answer? Agree, disagree? Okay, that's good. Okay.
How about the pretracheal lymph node metastasis in upper thoracic esophageal cancer? According to the 11th edition of Japanese classification, is regional. So what's your opinion in Japan? If there is pretracheal lymph node metastasis in upper thoracic esophageal cancer,
upper thoracic esophageal cancer?
Yeah, upper thoracic.
But still, generally 106 is identified as a distant metastasis.
Even in upper thoracic esophageal cancer?
Yes.
So change
that's,
it
that's why we don't do
the
dissection of the 106 routinely. But in some cases, just a special, for a single metastasis, and the patient is in the National Cancer Center Hospital, those patients can be treated with, local resection with 106 pre.
So in those cases, you don't dissect the pretracheal lymph node?
Yes, routinely. But in some cases, actually, especially the 106 period exists very close to the 106 reg R or something, we can dissect that, technically. Yes. Okay. Could you answer again? Okay. Agree?
Yeah.
Or disagree? Yes, personally.
Because in our practice, we routinely dissect the pretracheal lymph node. Yeah. And seems that no matter the tumor location, the presence of metastasis in this area is not so different from the clinical outcome is not so different from the other side. So it is our routine practice also oncology profession. I think we can assume appearance feeling that this group of patients should not be classified in another group. We just because once is routine dissected and the long-term outcome is not so different, it's no reason to classify as distant metastasis in our practice.
But how about 113 or 114 intermediate lymph node? Do you regard it as regional?
What was
intermediate stain?
Intermediate stain, yeah, it's very few, but if we want, it is not so frequent accounted. But if it was specified area, we just dissect it. If it is completely dissected and no other residual disease, we still think it is regional. Yeah. That depends on whether the complete lymph node dissection can be dissected completely. It is not cannot reach the surgical resection. We will think it will classify as a metastasis, but it can be reached by a surgical field. We still think it as a metastasis.
What do you think of it?
Okay, that's a very good point. Yeah, actually, 113 and 114, such a, definitive anterior metastatic lymph node should be, considered separately from the 106 pre lymph node. Yeah, a little bit different, I think. Yeah, I also believe that, such a, 113 or 114 or a definitive systemic disease, but 106 pre, part of 106 pre might be a local disease. For example, as I told you, where the location is very close to the, 106 record or something. Okay, but under the other opinion is maybe difference between the esophageal surgeon in Japan and the thoracic surgeon in the Korea or Taiwan. We are not familiar with the pretracheal region anatomically because we are just the esophageal surgeon, not lung surgeon. So that may be the based difference between Japan and other Asian countries. Okay, what about China?
Just one comment you can think about that. Based on your clinical data, is that common recurrence, local recurrence for 106 pre? I think in China, in our center's data is very rare for local recurrence because we do not routinely resect that area, but very rare local recurrence. But if, as I said, if it is positive, it is a high burden for tumor, I think. So this question, I think we should follow the TM stage standard right now.
Okay.
Yes.
That's a good point, actually. In the era before the immune checkpoint inhibitors, the existence of the metastasis in the 106 pre, therapeutic value index was very low. Yeah, no survival.
I performed several cases for resection of 106 pre because formerly we do not do, but after chemoimmunotherapy,
right?
Yes, some enlarged, and the PET CT scan also showed that it is positive. But PET CT scan in a year old of immunotherapy is very controversial. So we cut the stations of lymph nodes, but it's all negative.
Yeah, in the era of the immune checkpoint inhibitors, we can have some, effect of the resection of 106 pre in some part of patient, I think. Yes. So next question.
Sorry. There is a local treatment indicated for the patient with stable disease showing a tentative progression, but not progressive disease after systemic therapy. What treatment you recommend? Local treatment or continue systemic therapy?
Okay, could you answer? Okay, so that's a good question, but a very difficult answer. Yes. First, I'd like to ask Professor Tsushima. Yes, why you answer disagree?
Yes, I believe local therapy is conducted for the patient who are in good control. So if the tumor show the trend of progression, it's not good candidate for local therapy, I think.
Okay, any other comment from Professor Matsuda?
Yes.
Oh, yes, thank you. Yes, I agree with Dr. Tsushima's comment. At the bottom line, this patient has the M1 disease patient. So initially was not a good candidate for local treatment. And then, yes, and then even though that is stable disease, but the cup of the lesion trend to progress, that indicating that systemic treatment is not the controlling the systemic disease. So even though we provide local treatment, those patients would have the early recurrence, so might not be a good candidate for the local treatment.
Okay, so Dr. Matsuda, in this case, you will continue the current regimen, drug therapy, or switch to the second line.
Yeah,
we have no choice.
Yes, until this patient show the clear progressive disease, we will continue the same regimen.
Okay.
So you said actually for ESCC, the subsequent treatment regimen activity is not so good. So in this case, I usually continue the systemic treatment with adding some local therapy. But in this case, local therapy does not mean the surgery. Surgery is too aggressive in this patient. So I usually add some radiation to the patient who are progressing slowly.
Okay, Professor.
Yeah, I agree with his comments. That's also the common practice for us in treating metastatic disease. When we treat the patient who had some progressive disease in certain lesions, but overall the condition is still within the stable disease, we will consider adding some local treatment to those progressive lesions and then continue the same immunotherapy containing regimens. So that's something we think about, that local therapy might be able to eradicate some of the resistant clones or lesions from the patient.
Okay, any other
answer is local therapy, agree. Continuous systemic therapy, agree.
Okay, good answer. Yes. Any other comment?
Yes, it depends on the local therapy. So in this case, as Dr. Hong said, surgery should be avoided, but maybe radiation or radiofrequency ablation may be considered.
Yeah, we have a radiation therapy as a good candidate as local therapy. Okay, very good point. So, any other question?
No.
Last question?
Yeah, no. Next. Next is a local treatment indicates the similar score the stable disease, but showing the tend to shrink it, but not achieve the response.
Okay, could you answer?
Agree? Disagree? Oh, almost agree.
Rest of them, you have a time to consider, right?
Yeah. Because in our daily practice or MDT, those patients, if has a trend for shrinking further, we will sometimes give more cycles, systematic treatment. But some of the patients we will choose directly resectable or combined radiotherapy. Yeah, so that's what I'm hesitating. Yeah.
Very, very good point. Any other comment?
So it depends on situation that some patients show induced oligometastasis. Initially, the patient has a lot of the disease, but after the chemoimmuno, then some patients, we can induce the patient from multiple metastasis to oligometastasis. In that case, sometimes we can use the surgery in that case. Yeah.
Yeah, depends on the person, Kim.
Yeah. I think RT seems good, radiation therapy seems good. Yeah. Because also quality of life is also very important. Yeah.
Okay. What about in Taiwan, personally?
I also agree the local treatment should be applied to this patient. But what kinds of local therapy should depending on the site and the condition of the patient. Because shrinkage does not mean that this resolve of the disease. And it will be possible in the final they will flare up of the disease. And in the other word, local control is very important for such patient. So just waiting instead of waiting for flare up or disease progression, we just in the first moment to get a better chance of control of the tumor. I think the patient will have the best chance of survival long term in the future.
Okay, next question.
That's the results of the our OMESC4. This progressing SD, shrinking SD. So this data is based on OMESC4 results. So the next is metastasis, lung metastasis in case of metachronous unilateral.
Can you stop and reverse? Yeah. What about CR lesion? Yeah. I mean, yes. Do you need local therapy for CR region or that? Why not? Yeah, that I think it should be answered by the panelists. Yes.
If patient achieves CR, I think local therapy is not induced right now, and continue systemic therapy for a while or just observe.
What about Dr. Matsuda as a representative of the surgeon?
I have the same opinion. I don't provide the local treatment when the patient enters CR.
But actually, you can see that the results, agreement and the disagreement is half and half, right? Yes. What is this interpretation of that result?
Yeah, that's the very difficult, but I think and I wondered this clinical response, complete response region. So that's please wanted to reject. I consulted the surgeon, but the results of the rejection, the lymph nodes or liver metastasis, but that's a residual disease. So that's I think I want to be the complete CR lesion, so I want to reject it. So but that's very invasive, and I asked our multidisciplinary team and this OMESC for the results not. Almost the comments not needed this local treatments. So that's what is the definite or what is so I don't know, but so this clinical response region. So then so sorry, the patient received the systemic therapy, and after the testing this clinical CR, so long time CR region, but this is so I don't know.
May I so just a comment, and The CL situation is depend on the accuracy of the diagnosis, and sometimes we do not do the accurate diagnosis mainly for the primary region. So using the PET scan and endoscopy, and so how to treat it? The primary region, especially primary region. Which diagnosis as the complete response clinically. So I agree with that. So metastatic region have achieved a complete response. It is not candidate for the local therapy, but that depends on the primary site or the metastasis. They made different opinion. So I would like to ask
Yeah, that's a good point. Good point. Dr. Matsuda, when the metastatic sites disappeared clinically, I think you try to resect the primary tumor, as a conversion surgery, right?
If M1 disappeared and then still we see the local disease, we will consider the surgery. But if we didn't see anything in the primary tumor, we might, at this moment, we might consider the follow-up or the continuing the systemic treatment.
Okay. When the primary tumor is very controlled, right? So what about in China?
It's very discrepancy, but in our center, based on the MDT discussion, I think most of the kind of CR patients, we will not add the local therapy. Most sustain systematic or ICI for those patients for organ preservation. Yes.
Okay, thank you very much. So next, okay, so next question.
Yes. So the next question is lung metastatic cases. In case of metachronous unilateral metastasis, should local treatments be considered for 3 metastatic lesions as an oligometastatic disease? Lung unilateral 3 lesions. So what's the treatment you recommend? Local treatments or continued systemic therapy?
In this case, we already provided systemic treatment.
Yes.
And then after that, we still did see the 3 metastases.
Still 0.
Yeah, very difficult question, I think. Yes, could you answer anyway? Okay.
So recurrent disease, recurrent.
Yeah, metastasis, metachronous unilateral metastasis.
No primary or regional lymph nodes. Only lung metastasis.
Okay, Professor Hong, any comment?
It also depends on the situation because if the patient had right lung metastasis, and one in right upper lobe, one in right middle lobe, and one in right lower lobe, I think that's not be the candidate for local treatment. But the patient has the 3 regions on the right middle lobe, that will be good candidate for local treatment.
Yeah. What about Professor Kim?
Also it depends on the location of the metastatic lesion. If it is located in the superficial lesion, we can do it by simple wedge resection within 30 minutes or 40 minutes. But if the lesion is located deep in the right upper lobe or right lower lobe, local therapy, so especially surgery, is not a good option. Yeah.
3 metastasis is acceptable? Up to 2?
I don't know. 1, definitely I'll do. 2, I'll do maybe. But 3, maybe the benefit will be less than that I expected. Yeah.
Okay. What about, Professor Lee?
also agree with Professor Kim. Is 3 is not just only depending on the number. It should be depending on the location and laterality. Is the same side that we can resect the peripheral very quick, just in a couple of minutes to resect the lesion. I think it should be classified as oligometastasis, but it is we have to open the other side of chest, or it's very deep-seated, very hard to control with lobotomy. I would not think that this is a metastasis, but in general, in 3 metastases in the very simple area, we can agree with that. So it is just in case in some circumstances.
Yes, Professor Xu, any additional comment?
No, I think we are talking about the surgical resectable or technical resectable 3 lesions, because Professor Lee and our chest surgeons are very capable. They can, if they consider easily manageables, I think we will consider them as oligometastasis in our center, I think.
Okay, Sophie.
I think this is the question is the biobehavior, is that equal to oligometastasis for 3? If the question it is consider 3 metastases plus ctDNA negative, I will choose. But if 3 metastases, the biobehavior for the tumor or cancer, I think it's not a resectable or not resectable question. It is cancer question, I think. So that's why I disagree some kind of, because based on breast cancer, colorectal cancer, there have a lot of data for showing the lung metastasis. We can see as a thoracic surgeon, we cut some tumors like that, but mostly less than 3. Yeah.
Okay, it's fantastic, idea using liquid biopsy. Thank you very much. Okay, so next.
Yes, that's a liver metastasis. That's the same question. So in case of metachronous unilobar metastasis, should local treatment? So this is 3 metastatic lesion.
Okay, could you answer that?
After a systemic treatment.
Yes.
Yeah, or disagree.
Yeah.
Oh, Professor Xu, agree? Okay. Okay, Professor Xu.
But my answer is actually the same as the previous questions. Okay, this is even more restricted to the 1 anatomic locations, and so I would definitely consider that should be considered as oligometastatic disease.
So, Professor Kim, any comment for that? Okay, Professor Hong.
In my limited experience, that the liver metastasis usually means system failure. So in the case, adding the local treatment without changing the systemic treatment does not provide the good result. And especially in the immune checkpoint era, the liver is kind of the sanctuary, the organ to the immunotherapy. So it means a very bad prognosis. So in the case, the local treatment has no role in this case.
I have to admit, I did not read the question well. I thought it was about the lung metastasis. No, so I disagree. So it should be the same.
Yeah, okay. Yeah, even if the number is the same between the lung and the liver, that the clinical meaning is quite different, I think. And also, technically in surgery, hepatectomy to resect the 3 regions is not so easy, I think. Yeah. So that it's very good question, but okay, next.
Yeah, that's the results of the OMSC4 results. So the lung and the liver metachronos unilateral data, the 2 region is consensus, but 3 is not consensus at the fair agreements.
Okay, I understand. Any comments from the panelist? Okay.
So
okay.
I think based on these results, you don't worry about that because every time the results should be improved, not always follow the former ones. Yeah. You think it's different like the former ones is wrong? No, maybe no. Yeah, they should improve. Yes.
I would ask Professor Nomura. Yeah, yes. The definition of oligometastasis, you consider a difference between the synchronous and the metachronous.
Yes.
What's the reason why?
The synchronous oligometastatic disease have the primary and regional lymph nodes. So the totally tumor burden, the difference, the metachronous or synchronous disease.
Okay. Do you agree with his opinion? Any other different comments? Okay. The other question is, when comparing the OMESC project and the OMEC project, the number of metastases is a little bit different in the definition of the oligometastasis. It is acceptable up to 3 metastatic lesion, metastasis in the OMEC project. But you want to, define your oligometastasis up to 2, right?
Yes.
Yeah, currently.
Yeah.
What is your idea of that?
Yeah, that's their data and their patients, adenocarcinoma disease, but our esophageal cancer patients have the squamous cell carcinoma. So that's very aggressive, and so the limited this data. So I acceptable this data compared to the difference the OMIC.
Okay. Finally, I want to ask all panelists the same question. When comparing the OMEC and OMESC project, what is the difference? Of course, that's the difference between the adeno and the squamous cell carcinoma. For example, in terms of the number of the metastases, do you accept the 2 up to 2 lesion is a good candidate for the oligometastasis? Do you agree that? So, Professor Shu?
I think that's better to be started with Japanese colleagues because the OMEC4, many of the doctors participating in OMEC4 are from Japan, right? So it's better to start with Japanese colleagues.
Okay, I think we Japanese doctors are not too aggressive to metastatic esophageal squamous cell carcinoma, and I think it's better to less number of metastasis. I think it's good to provide local therapy for less number of metastases.
So, Professor Matsuda?
Yes, I understand that the difference between there is a difference between East and West, but those difference comes from the difference in the local treatment. The surgery is totally different. Although we need to consider the CRT, but in most of the answer, the panelists or the surgeon. That's why they are always thinking that local treatments can be equal to the surgery. That is the case. The surgery plus metastatectomy, the level of the patient invasiveness is a difference between OMEC and OMESC.
Okay, Professor Leng?
So adenocarcinomas and S is totally different. In American, based on the consensus from the AATS, they have divided.
there are two different kinds of disease. So I think just as I said, the former literatures or references we can read and see, but this is the East Asian patients and squamous cell carcinoma. So no challenge and no improvement.
That's a good point. Thank you very much. Okay, Professor Lee.
I just comment about the lung metastasis because in the other cancer with lung metastasis, the resection is quite not depending on the number and also depending on the location. If we can resect all the tumor, the outcome of lung metastasis of other cancer is quite acceptable. And most of the such a certain long-term outcome is comparable to local regional disease. So I think from lung metastasis, 3 is not a question, but depending comes again, depending on the location. Location of tumor is a resection. It should be very aggressive, and the lung function can be impaired with the resection such as lobotomy or pneumonectomy. I think it's not suitable, but just a simple way you can resect all the tumor. The outcome should be acceptable. So number, even though it's metacoronous, I still agree with that can be local treatment. And liver also if it's just only here there, because our liver team also very aggressive. It's just abrasion. So for such patient, it's very rare to just a surgical resection. But instead, they will do abrasion. The abrasion is totally quite straightforward. The patient just minimal invasive recover very quick. So there was no reason to just reject the patient for local treatment for such patient.
Okay, Professor Hong.
You asked the difference between the OMAC and OMASC. It's not easy question for me because the last time I managed the gastric cancer or esophageal cancer was past more than 15 years. So I don't have much experience. And at that time, 15 years ago, there was not much discussion on the oligometastasis. So yeah, I have very limited experience in adeno. So it's not easy to say.
Okay, thank you. So finally, Professor Kim.
Actually, I don't know because I don't know the surgeons or medical oncologists who was participated in OMEC trial. But I think there may be a difference in philosophy. So maybe our Asian doctors' goal for oligometastatic disease is to cure the patient or to prolong their survivor. So maybe for me, I don't want to make disappoint to our patient. So if we extend our indication for oligometastatic disease, some of patients cannot get any benefit from those treatment. So in that case, our treatment or effort may be the futile or useless. So I want to avoid the situation. So we need to make the more strict indication for oligometastatic disease. Yeah, that's the way to make our treatment be effective. Yeah.
Okay, thank you very much. So it's time to close this session. Finally, Professor Xu, closing remarks or something?
Okay, I can agree more with the comments of Professor Kim. And also, I think if we go back to the very beginning of our meetings, the definition of oligometastasis. So we are thinking about the metastatic disease that not only be surgically or locally treatable, but also should be cured with curative intent. So if you go back to that definition side, I think our OMAS 4 conclude with a more strict definition of oligometastasis should be a very good one. So
Okay.
I should congratulate Dr. Nomura's efforts.
Okay, thank you very much for a very wonderful presentation by Professor Nomura and following very constructive and engaging discussion. Thank you very much.
Okay, so thank you for the hot discussion. That's a morning session, and did you enjoy the sukiyaki lunch? Okay, yeah, and maybe that's slightly we're gonna sleepy at this time, but I hope that's hot discussion for the afternoon session again. For the session 3. So I like to propose the OMEC5, the prospective randomized trial design and structure. And I would like to discuss today. I think that it's not sufficient time to discuss to conclude definite design, but it also I like to continue with the discussion based on today's discussion. Okay. So firstly, I like to talk about the elements of the protocol concept. First, the clinical question, and second, the subject, and the third, the standard of treatment, and the fourth, the experimental treatment, and then finally the trial design and endpoint. So first of all, I like to explain about the OMEC project and the OMEC5 trial. So already Professor Nomura mentioned about that. The OMEC5 trial just started this month. So firstly, this trial was conducted as a ERTC study, but they cannot get the whole budget. So Dr. Heineke managed to get a smaller budget with Amsterdam Medical Center, and building protocol group with OMEC5, and finally the OMEC5 were launched this year. So the OMEC5 trials follow the OMEC consensus. And that include 3 or fewer lesions within one organ or one extra-regional lymph node metastasis. And also the liver metastasis and 3 or fewer lesions or 2 or fewer lesions in both lobes. And then the first 3, patient enrolled this trial. 4 months of the chemo-IO therapy was continued. And if patient achieved non-PD, and the registration was performed, and assigned to the initial local therapy, followed by the chemotherapy, or adding the 4 months of the additional chemo-IO therapy, and then the restaging was done, and local treatment was done. So I would like to explain about the OMEC5. So clinical question is this is from protocol of the OMEC5, and approved as patient with esophageal and gastric cancer with oligometastasis, treated with extended standard care and systemic therapy followed by local treatment. We experienced and improved survival compared to the shorter duration of the standard of care systemic therapy. And the subject is this inclusion criteria of the OMS5 trials, the age of the 18 and more, and the histological approval and the junctional and the gastric cancer. And the definition of oligometastasis is, as already mentioned, about that. So three metastasis, one organ is so basic. The status of the OMIC, consensus. And one bone structure or the one soft tissue component is allowed. Okay, and the metastasis, and so the definition of the oligometastasis is so amenable by the international MDT for the radical therapy. So this is so figure of the OMIC5 trial. And so they said that multidisciplinary the external review of the oligometastasis contained in the three imaging specialists and three HPP surgeons, three upper GI surgeons, and three radiation oncologists and three medical oncologists. And the review was performed initially using the imaging by the local hospital, then the platform using the digital platform. Okay, so. And then OMIC5 set the standard of treatment, systemic therapy with the local treatment. And the local therapy for any residual disease site with patient who achieve a non-progressive disease after 4 months of systemic chemotherapy, including ICI, set as the standard of treatment OMIC5. In general speaking, the continuation of the systemic therapy is the standard of care for the stage 4B and the recurrent patient. But they say in such so they think the major inclusion difficulties arise if they set the standard of treatment of the continuation of the systemic therapy. So they said including a local therapy component, both of the standard treatment and the experimental arm treatment, and they decided to compare the duration of the induction therapy before the local treatment. So they say that this is not the phase 3 trial, not the definitive trial, but the experimental trial, so hypothesis making trial, and as a randomized phase 2. Okay. So this is experimental treatment of OMS5, additional 4 months of the systemic therapy followed by local treatment. And this is trial design, as I mentioned about that. And they have conducted correction of the biomarker, including the liquid biopsy, to making using the decision of the additional design of the local treatment or not. Okay, and the randomization is performed. Is here, but the patient was registered before the initiation of the first chemotherapy. So they say that this is randomized 2 trial, on the phase 2 trial, and the primary endpoint is progression-free survival, and they defined as progression from the date of the randomization, or the death, any cause of death from the date of the randomization. The secondary endpoint is OS and quality of life. So another patient is calculated by the hazard ratio is around 0.70 with 80% of powers. Okay. And it's set as 290 patients will be enrolled. But in case of the modest hazard ratio, as seen, they will enroll the more patient to grade up the power of the calculation. So the treatment design was resembled as typical phase 3, but not the phase 3, but so randomized phase 2. And they said that. So of course they know about the random phase 2. That's not a confirmatory trial, but it is very difficult to do the similar trial. So they think that the result of this trial would be the conclusive result, and maybe adapted for the treatment guideline of the ESMO, maybe. Okay. So this is a summary of the OX5. Yeah. And then as for the another trial, the evaluated the comparison between the continuation of the chemotherapy to the local therapy followed by chemotherapy, namely Renaissance, already presented in the ASCO meeting by the Professor Albatran. And this trial did not show the superiority of the surgery over the continuation of chemotherapy. This trial, the peritoneal metastasis patient was also considered as oligometastatic diseases, and then the subgroup of the patient with peritoneal metastasis shows obviously poor survival compared to the continuation of the chemotherapy. Okay. So the OMEC5 trial said that narrow window for the oligometastasis compared to the Renaissance trial. Okay. On the other hand, Shanghai trial showed obviously the better survival with local therapy followed by systemic therapy for the ESCC patient compared to the systemic chemotherapy arm. In this trial, the definition of the oligometastasis is a more narrow window. The all metastasis are less than 4 and is less than 5 centimeter, and all region can be treated by local therapy up at the beginning of the chemotherapy or the registration. And then 80% of the patients received the radiotherapy as a local therapy, and the surgical treatment, very small number of patients received, and all patients the systemic chemotherapy. So it is very quite different between the Renaissance and OMEC trial to the Shanghai trial. Okay. Okay, this is background in the another trial, similar to the OMEC5 trial result, according to the within the gastric cancer and the esophageal cancer. Okay, so at that time, any question and comment for the result of the OMEC and the Renaissance and the Shanghai trial?
Dr. Kato, may I ask one thing?
Yeah.
I couldn't fully catch why the OMEC5 cannot be dealt as the phase 3 trial. Is that due to the number of the population, or the study design or aim?
Yeah, so I'm not contribution of the clinical trial design. Yeah, but finally they decided to do the phase 2 trial, not the phase 3 trial, because they worried about the consent from the patient is the main reason, I think. Yeah.
So they are concerned due to the concern of the patient enrollment, they cannot plan the bigger trial. That's why they need to minimize the sample size, and then it was kind of classified as a phase 2. That is right.
Yeah, maybe.
Okay.
And so usually after the randomized phase 2 trial, so confirmatory trial using so compared to the standard of care, so continuation of the chemotherapy would be planned. But in the protocol, the OMEC5, the no description about the next plan after the OMEC5 trial. And then they describe that it is very hard to conduct the similar trials. So
I
maybe
understand.
Yeah. Okay. Okay. Any other comment? Okay. Okay. So moving forward to about the OMASC project. And so already the Dr. Nomura mentioned about that. OMASC project was going through the OMASC1 to the OMASC4. And the good discussion and the good meeting was held in this morning. So the discussion will be helpful to make it concrete. That's a consensus for the further clinical trial. And again, so we consider about the element of the concept part. Okay, so I would like to ask for the discussion. Wait. Okay. Okay, first question. So clinical question of the OMESC5 is in ESCC patient with oligometastasis defined according to the OMESC consensus, does additional local therapy improve the outcomes and where are the appropriate timing and method of the local therapy for the ESCC patient with oligometastasis is a clinical question of the hypothesis of the OMEC5 trials. So do you agree or disagree? So raise Japan. Dr. Nomura? Okay. All the discussants agree that this clinical question. But did Dr. Nomura had some opinion for that? So missing a component is exist for that? No? You agree? Fully agree? Okay. Partially agree. Okay. Okay. So next question. Yeah. What is the subject of the OMEC5 trial? It is not so sorry. It is subject from the OMEC5. It's a historically proven ESCC patient. And then the definition of OMESC4 is followed. So the definition of the slightly small window with the OMESC4 trials. So do you agree or disagree? Okay. Or neutral. So says.
What does
Mostly.
does the third description means? After enrollment or before enrollment, the definition will be changed based on the central review.
Yeah. So the OMEC5 said that so that they should review the external review would be so needed. So it is a one point for that one discussion, another discussion point. Okay.
How about the third one, the PD-L1 expression levels?
Yeah, so it is one of the key project. Of course, this discussion is the next story, and so according to the standard of care. Okay. So firstly, the consensus for the MS4 is adequate, or the more wider the definition is needed, additional to the consensus, the MS4 consensus to be right. So, how do you think, the Professor Ren? No. So, how about Professor Hong?
Yeah, I agree with the definition in lung, adrenal gland, and bone and extra-regional lymph node, but I cannot agree with the definition of oligometastasis regarding liver. So yeah, but the metachronos, two or less regions, I think that is for indication for palliative chemo.
Chemo, okay. Two region,
yeah,
is so many, too many.
Also, already Professor Sherry mentioned that even some patients respond to immunotherapy in PD-L1 0. So I think we should change we should expand the indication to PD-L1 CPS 0.
That does depend on the clinical trial design. Yeah. Okay. So I said small definition of the MS4, and so I would like to discuss about the inclusion criteria in the clinical trial design. So after that, okay. So and then what is the standard of treatment? So continuation of the systemic chemotherapy, and then if the PD-L1 status is positive according to the patient adaptation, so using the chemo plus PD-1 antibody. So do you agree or disagree? Agree. So please raise your.
I don't understand the question. That what is for whom? For after local treatment or
so at the time of the registration. So for the oligometastasis, the patient with of the ESCC with oligometastatic diseases. Defined roughly defined as the OMS consensus. Okay. The Professor Ren also the disagree. Okay.
Because now the standard treatment is very controversial. So I think that's why you need to do clinical trials for that continuous systematic chemotherapy. If oligometastasis located there, that means you finished some period of systematic therapy, but it's still there. So continuous systematic chemotherapy may be controversial. So I disagree with that. Yeah.
Okay, so your opinion is already the system plus local therapy.
Yeah.
So should be done for the oligometastatic diseases. Right?
Yes.
Yes. Okay. So another opinion. Okay. So how do you think that, Dr. Matsuda?
Yes, I think that the initial treatment for metastatic disease, even though the pattern is oligo, still current standard treatment is a systemic treatment. But as Dr. Len said, we don't know if adding that local treatment is better after after the initial treatment. So we need to evaluate in the clinical trial, but yeah, standard treatment or at this moment, yeah, the majority of the clinicians are providing systemic treatment.
Okay, so still standard therapy for the distant metastasis cases is the systemic chemotherapy. Okay, so how about Professor Hong?
Yeah, I agree with that too. Completely agree.
So maybe the Shanghai trials is done in China. So inside China, so the consensus of the local therapy will be established already for the local therapy.
So I think we lack of consensus for that topic, but during the daily MDT discussion, local therapy always added. Yes.
So, but it still remained discussionable, I think. So, do you agree that as a clinical trial, so not practice as a continuation of the systemic therapy?
Yeah. Okay. But back to this question, if master choose one, agree. Yeah, there's a standard treatment. Yes.
Okay. And then the opposite question, the combination and any local treatment is agree with only by the Professor Ren, but another discussant will disagree the standard the discussion for the standard treatment. Okay. Okay, thank you. So do you have any additional comments from Dr. Nomura? No additional comment.
Yeah, I agree.
Okay.
About the standard care treatment, standard care just previous, because we have the encouraging criteria about the PDR expression. So is the rationale of we standardize the systemic chemotherapy, and so if the patient included just only the PD-1 expression, so is it possible just with the standard, because we have included such group, and some data always shows with plus IO were improved. So if can we add just not only chemotherapy or maybe add some with immunotherapy continuously?
Yeah, so it is another point of the discussion for the inclusion criteria. So I think so if we okay, so okay. Professor Kim.
Okay.
So
can you hear me? Can you hear me?
Yeah. So I can hear you.
Okay.
So
I think regarding the continuation or discontinuation of systemic treatment after local treatment, then I think there is no consensus regarding that issue, and I think systemic treatment can be continued or discontinued at the treating physician discretion, and after that, we can analyze retrospectively, and we can analyze the retrospective outcome of the patient based on the ctDNA analysis, and that would provide some question for the future study. And I think that our systemic treatment can be discontinued or continued based on the treating physician discretion in this study.
Yeah. So it is good point of. Yeah, so we hope the treatment decision will be done by the liquid biopsy or something other information. We expected further the improvement. It's a more accurate decision we'll be making for the local therapy. Yeah, it is be helpful. Thank you for your comment. Okay. And so Professor Lee asked me about that. So how do you treat it for the PD-1 negative patient? In Japan, we can do that. So use the ICI regardless of the PD-1 status. All patients can be the candidate for the ICIs. But usually, so other countries and even in the Western countries, ICI so only used for the PD-1 so positive patient. So the Professor Lee mentioned so this so strategy is so for the PD ICI it will be so suitable for this trial. So what can we do for the patient who cannot so use the ICI? So, Dr. Nomura,
so the more without the systemic therapy without the ICI, so with plus local therapy, so that's a little more improve the survival, but compared to the systemic therapy without ICI, so this is I think the same strategy. So or regardless of the regimen. So I think
so both the ICI patient and the non-ICI patient will be the candidate for this trial. So Professor Hong, so what do you think about it?
I'm a little different. I have a little different opinion from Dr. Nomura. Yeah, because we used the cytotoxic chemo without IO for a long time, but the activity is quite limited. So for that patient, that the treatment, local treatment for oligometastasis is, I think it's not enough. So I want to the inclusion criteria the treatment should be IO plus chemo. So we
chemo only. Okay. So Professor Xu, so medical oncologist.
So I think I would for this criteria just to enroll the patient with the PD-L1 expression.
So treatment will be
I can imagine if we enroll patient with PD-L1 expression negative patients, and these patients probably will be treated with different strategies in different countries. Like just probably in Japan, you still will try use ICI based therapy to treat them, but in Korea, in Taiwan, I think we will just go for chemotherapy. So the second thing is that the patient with PD-L1 negative actually probably just comprise of a very small fractions of ESCC patients. So probably will lose about 10% of patients. Probably do not hurt the trial very much. So probably just go for more homogeneous populations.
Yeah, thank you so much. And I agree with that. So the component of the ICI is so helpful for the long durable response and suitable for the local therapy after the adjuvant only with ICI chemotherapy is suitable for that. So Dr. Masa, what do you think about that? And so in Japan, so we can use ICIs regardless.
Yes.
And some patient respond. So even the PD-L1 negative patient population.
Yeah, that's true that we can use ICI even the CPS negative. And also, I thought that the definition of oligometastasis is that regardless of the initial treatment, we can treat that patient with the local treatment at any time point. So based on that definitions, we might not too focus on the treatment regimen. So starting point might be better to include all the CPS status, and then even without immunotherapy, we can provide a systemic treatment and then keep the stable disease, we might be able to consider local treatment. If that is the case, the inclusion criteria can cover everything. That is my opinion at this moment.
Yeah. No, thank you. So Japanese investigator applied for that. We should enroll all the patient with another. So how do you think that from China? So
I think in China the same PD-L1 negative positive we can all use, no matter lung cancer, esophageal cancer, the same, because the clinical trial shows the positive results for both. But PD-L1 positive is more better. It's just it. So for clinical trials, for this, I think it's hard to enroll. So more patients, more better.
Wider indication will be this. And of course, so I remember some patient, before the ICI era, respond to the 5FU cisplatin only. And some patient, but it is very rare to move to the so-called conversion surgery or something like that. So Dr. Matsuda have a data of the conversion surgery.
Yes. Without the ICI treatment, we can refer the JCO 1314 conducted by Dr. Tsushima. In that trial, we enrolled all the metastatic patients, and then the conversion therapy was not included in the protocol. But in the post-hoc analysis, around 13% received the conversion surgery or the conversion CRT. That's why even without the immunotherapy, some patient might be able to undergo the local treatment when we start from all the metastatic treatment. So that's a local and a smaller population, but that is one of the reasons why we might be able to include this population.
Yeah, thank you for the important information. The JCO 1314 is a comparison between the 5FU cisplatin process, 5FU cisplatin plus docetaxel without the ICIs. Only by the chemotherapy. So 13. Yeah, so relatively higher than I imagine. The patient does go through the local treatment. Outside of the clinical protocol. So that is good news. So regardless of the ICI usage, there's a patient who achieved good response. Would be the candidate for the local treatment. So Dr. Matsuda's information show that this fact. So do you agree this? Yeah.
Our data also shows that
the number is actually quite small. Because,
maybe that's so. Yeah. So
it's less than 10% of ESCC patients will be PD-L1 negative. And they will be treated with chemotherapy alone. Then 13% of them will
very small.
Yeah, it's
let me add, the 13 is not the target. The inclusion of the 1314 is all the metastatic patients. So probably if we selected only the oligometastatic disease in 1314, although we cannot do that, but probably the percentage might increase. But as you said, still PD-L1 negative is small population.
Yeah, but there's wider indication, would help for enrollment. That's clinical trial, I think. Yes, thank you for the productive discussion. Okay. Professor, Kim, Dr. Kim.
Okay, can you hear me? I think I'd like to suggest that restricting patient enrollment based on PD-L1 status would be very challenging because one of the major challenging issues in oligometastatic disease setting is patient enrollment, and that's the reason why I would like to suggest that a patient can be enrolled irrespective of PD-L1 status. And however, it may be better to require investigators to submit PD-L1 result and to pre-specify which clone should be used and which scoring system should be used to either TPS or CPS or both. And I would like to suggest that submitting PDL result based on standardized manner would be a better option for this oligometastatic study.
So, your opinion is just the PD1 status should be the certified for the randomization?
I think in this study, we can use ICI and chemo-based strategy. However, in this study, I think the only systemic cytotoxic chemotherapy would be one of the option. And I think rather than selecting PDL status as a stratification option, I would like to suggest that that would be one of the subgroup analysis in the post-hoc subgroup analysis factor rather than stratifying factor regarding PDL status, I think.
Okay. So I agree with you. Yeah, thank you for your comment. Okay. Move to that discussion about the experimental treatment. So we considered some the experimental treatment. So upfront local therapy followed by systemic therapy, like is Shanghai trial, or systemic therapy followed by local therapy for any digital diseases. So, which do you prefer? And so, firstly, I would like to ask, so the upfront local therapy followed by systemic therapy, do you agree to for the experimental treatment of the OMESC5 trial, or disagree? Okay. Disagree, but the Professor Xu, so neutral. Neutral. I disagree. Okay. And so how about the systemic therapy followed by local therapy? So do you agree for the experimental treatment for the OMESC5 trial? Okay.
Yeah.
Comment.
Anyway, the oligometastatic disease is metastatic disease. So the patient survival mainly based on the activity or efficacy of systemic treatment. So we should state systemic treatment first, not rather than the upfront local treatment. And our hypothesis is the adding local treatment to the systemic treatment may cure some patient. So that's our hypothesis. So this should be our experimental treatment.
Yeah, thank you for. So fundamentally, the oligometastatic disease is a so-called systemic disease. So after the systemic therapy, if the systemic control is well, the patient goes through the local therapy, and then the local therapy may improve the survival and something like a curative intent is the clinical question of this trial. So. Okay, thank you for discussion. Okay, so I would like to present the 3 clinical trial design. It's very complicated. The first plan A is most theoretically design. Firstly, the patient enrolled to this trial and the systemic therapy for a period, and then the patient they achieve the non-progressive diseases. Randomized standard treatment. With continuation of the chemotherapy with or without IO until PD. Or the experimental treatment is local therapy, and then the adjuvant treatment is a plan A. So issue is the enrollment and the patient refusal is a concern for this clinical trial design. Okay. And then so plan B is like a OMEC design. The both arm containing the local treatment component. But it also continuation or firstly systemic therapy first, and then the non-PD patient assigned for the local therapy followed by adjuvant therapy, or the additional systemic therapy followed by local therapy and the adjuvant IO. So the concern of this design is not confirmatory design, because standard of care is continuation of the systemic chemotherapy. Okay. And then the plan C is similar to the ESO Shanghai design. So we said that standard of care is a continuation of the chemotherapy, and the experimental arm, the upfront local therapy followed by systemic therapy. Okay. Okay, so starting the discussion for the plan A. So how do you think about the concern about the plan A, or the good point or issues? So Professor Lim, so how do you think of the plan A? So your standard of care is systemic plus local therapy.
So in fact, I prefer plan A. Yeah, I prefer, because it is more, I think it's more accurate and easily to conduct compared to the other plans. So I'm not so good at the clinical trial design, but this kind of procedure, I think, is reasonable. Yes.
Okay. Okay, so Professor Xu, so how do you think about that?
I also agree that Plan A is my favorite designs, and but I just have some concern about the endpoint and the patient enrollment. And I just imagine if patients enroll into the so-called standard treatment arm in arm A's, and after a while of systemic therapies, if patients do have some early progressive disease, I think many physicians will go for local treatment.
So after the progression.
Right. Right. So it would turn out to be part of the patient enrolled into the standard treatment will receive local treatment later. So it's somewhat similar to Plan B.
Yeah. So does you mean that some patient who experience a progressive disease before randomization?
No. After randomization.
After randomization,
you'll continue the treatments.
Okay, so the subsequent therapy for the standard of care would be go to the local therapy.
I think some physicians will prefer local treatment. In some of the cases. So so in that case, so the difference of these two arms will be not local therapy, yes or no, is a matter of time. It's timing to give the local therapies. So in that sense, it's kind of similar to some extent, similar to the Plan B.
Yeah. Okay. So-called cross.
Right.
Yeah. Crossover.
Right.
Trial.
So when you examine the OS, then probably the subsequent therapy will impact on OS. So there's something, I don't know how we should
the magnitude of
the
hazard ratio. The hazard ratio of the OS is also more getting smaller. So by the crossover.
Right.
Of the local therapy. But so I think that so we cannot define to eliminate the local therapy after the progressive diseases for the standard of care. I think.
But since if the patient do have the progressive disease, you will leave the trials, and I believe the patients still have very limited metastatic lesions. Many physicians will go for local treatment, so you cannot.
Yeah. Thank you for the risk of the critical treatment.
So the issue second that I think must be set a duration for the treatment, because if you do not set the duration, the data is hard to analyze. I think you have no standard for how many cycles you use for chemo, immuno, for systematic treatment before the randomization.
So how do you think about the adequate duration on
maybe
that?
Two to four cycles may be okay, because based on the clinical trials for neoadjuvant, or if it is sensitive or stable for the disease, 2 cycles is 2 to 4 is enough. More than 4, I think is too much.
Yeah. So chemo pembro and the chemo tisray is every 3 weeks, and so 3 cycles is 9 weeks.
Yeah.
And then chemo nivo combination so is repeated every 4 weeks. So maybe we said that duration of the time period, 3 months or 4 months is a better for.
But this kind of patients are very complicated because it's metastatic patients. Maybe in different hospitals or teams, the patients, some will undertake 2 cycles, then randomized, and some maybe 4, even 6 cycles. So I think this part, just to give a note, just 2 to 4 cycles or 2 to 6 cycles, some kind of just let the researchers know, not too many. That's okay.
Okay. So Dr. Nomura, so from the result of the OMS consensus, what the duration of the systemic therapy before local treatment?
OMS4 consensus that recommended the chemo duration is 3 months. Yes.
Yeah, maybe the 3 months, and with some duration to allowed, so will be applicable because the time to response from the result of the pivotal trial is around 3 months or 4 months is approved. Okay, and then
Professor Xu has argument probably. No, 4 cycle is better, you think?
But I think for the metastatic disease, most of trial will say that patient can continue the treatments until disease progression or unacceptable toxicity occurs. In some of the trials, they will set a period of time, but that period of time usually is 1 year or 2 years. That's for metastatic disease.
Yeah, actually, we experienced the long durable patient with ICI. Some patient may refuse local treatment if they assigned to the local treatment arm. Yeah, that is another concern about that. But
I have some question that everyone agrees with the primary endpoint, the OSS.
Yeah, so I'd like to talk about the primary endpoint. Yeah,
I think that PFS is also a good primary endpoint for this kind of trial. And if we use the PFS primary endpoint, we can shorten the duration of the study period. And we can answer the local treatment will give us a kind of good impact to the patient or not.
Okay, so how do you think about the concern about the primary endpoint, OS or PFS? So Professor Nomura, so you're a medical oncologist, so so do you
Yes.
have any?
So I think the strict endpoints that's I recommend, but OS. But so I agree on Dr. Horn's opinion. But almost 4 or round. First round, the results, which endpoint you recommend? So OS or PFS or disease control rates. So the perhaps I remember the perhaps OS is 60% agreement, but PFS or disease control rate is 20 or 30% recommends that's the results.
OS is more than the PFS. Okay, yeah. Of course, OS is a true endpoint, and yes. I also concerned about the endpoint with the PFS because the treatment arm with the local therapy. So immediately no residual tumor at that point, but it also the systemic therapy group remained there. So the region. So of course it is easily to progress with standard of care group. It is my concern about the PFS. But yeah, of course, about the so making no cancer period give the patient is one of the true endpoint of the treatment. And how do you think the process use?
Just talking endpoint.
Endpoint, endpoints.
Yeah, I agree with you that OS should be the true endpoint of our studies, because the hope that we do the local therapy to oligometastatic disease is we want to cure a certain group of patients. So I think that could be better represented by.
But there's also some patients may receive the local treatment after the progression for the standard of care arm. Yeah, it is also some concern about it.
Yeah. So I just think whether the statistic experts can help us to take that into considerations. We need to increase the number of the patients sample sizes to overcome the potential impacts of the crossover.
Okay, yeah. So Professor Chang-Gon Kim, so have you
regarding the primary endpoint of this study, I totally agree with that. Overall survival rather than PFS is acceptable endpoint because many oligometastatic trials in many trials, interpretation of PFS after local treatment is very difficult for that kind of study, and that's the reason why I agree that overall survival should be the endpoint of this study. And regarding the study design, since this is a superiority trial for overall survival, not inferiority trial, I think it would be more appropriate to evaluate standard of care plus local therapy rather than local therapy alone in the experimental arm. And conversely, if you are planning to do non-inferiority trial, it may be acceptable to evaluate a strategy that omits systemic treatment in the experimental arm. And that's my suggestion for study design. And regarding the duration of initial systemic treatment, and in esophageal squamous cell carcinoma, there is generally an induction phase with platinum-based chemotherapy, and response rate or disease control rate are reasonably good after after induction chemotherapy, and therefore a study design involving systemic treatment followed by local treatment, with or without continuation of a systemic treatment may be appropriate. And accordingly, randomization between 3 and 6 months after initiation of a systemic treatment may be optimal, in my opinion. And regarding the refusal issue, and to minimize refusal issue, I think obtaining informed consent from the patient just before starting systemic treatment would be feasible to minimize the refusal issue during randomization. Although in that case, we can give up around 20% of patients who experience initial progressive disease.
Okay, thank you for the comment for the many point. So firstly, I recognize. So you mentioned about this. So the superior. So I think that this is the local therapy should provide a superiority over the standard of care here, because local therapy gives the patient harmful surgery or additional radiotherapy. So you mentioned about the non-inferiority design for this oligometastatic disease. So what is your opinion for the non-inferiority design, and what is the rationale for that?
I think that in this study design, new treatment is composed of local treatment with or without adjuvant IO. And however, I think with this experimental with local treatment with or without adjuvant IO, I think it is very difficult to prove overall survival benefit in this study, and that's the reason why I said that regarding the experimental, you should exploit SOC, standard of care plus local treatment, rather than just local treatment followed by adjuvant IO. And if you are planning to perform non-inferiority trial, then I'd like to suggest that just omitting systemic treatment with local treatment is the one of the feasible study design, because in that case we can omit systemic treatment just after local treatment, and I think that would be some of the non-inferiority design I would like to suggest. But I think conducting superiority trial required SOC plus local treatment rather than just local treatment in this study design.
Okay, so you mentioned about the systemic therapy, adjuvant therapy after local treatment.
That's right. That's right.
Should be done. Okay.
Yes.
Okay. Thank you. Okay. Okay. So any other point? Okay.
So for the primary endpoint, I think it's very easy to decide for the overall survival, because I remember Professor recommend that we must go back to the definition and the purpose. That's very important. One day you publish this paper, and the doctors use this paper, they talk to the patients. After this clinical trial, we use this method, can leave you live longer. That's very important. For example, we talk to the patients for breast cancer or colorectal cancer, we cut the local lesions, we tell them this can make you live longer. Okay.
Okay, thank you for the so important point. Yeah. So it may so the purpose of this trial to improve the survival of the patient with CSCC with the oligometastasis. So maybe the OS is just the no discussion about the point. Okay. And so the Professor Hong, so is it okay?
Yeah, I follow the majority.
Yeah. So, thank you for the good discussion. Okay. And so, so I think that some patient will refuse the randomization. Some patient refuse local treatment if the patient achieves complete response. And some patient mainly the stable disease patient willing to receive the local therapy if the patient assigned to the systemic diseases. How do we treat it for this issue for the refusal of the randomization? Professor Matsuda, is there any concern about that?
Yes, there are always issues about the randomization, but at least in this design, we can get a consent before initial systemic treatment. So after the randomization, we can tell the patient that we will continue the systemic treatment. That is your treatment arm. Then a couple of months later, even regardless of the treatment response, we just can follow the way. So might be in this design, comparing to the study design that we get a randomization before the local or the systemic treatment, the percentage of refusal will be minimized.
The importance of taking a consent before the initiation of the first systemic therapy is important here. And another trial in JCO, who get a consent and randomized after the response to the systemic therapy, it is very hard to consent. The concentration consent rate is around the 10% with all the participants. I think that I can compare the failure rate is similar to the both arms. It would be okay to compare to the standard of care and the nutrition arm. So how do you think about the proportion of the refusal patient? So in China, then situation about the consent from the patient and some refusal from the patient.
A high quality or this kind of clinical trial like IIT is very important that the principal investigator talk to the patients by themselves. So use their wisdom to talk to the patients because these kind of patients have no more choices for treatment. So I think in China, the risk of refusal is no, it's okay. It's okay. Yes.
Okay. So how in Korea? So the first home.
Yes, I have some experience that's and in this kind of trial, when a patient randomized to standard arm, then and the patient have some preference to get a local treatment, then they withdrew consent. So we cannot avoid. So as the professor told that the continuous conversation and the principal investigators talk and discussion will be very important to maintain the patient in the trial.
So you are a good doctor, for the patient. So how about in Taiwan? So Professor Su?
There is always a risk of patient will drop out. So I don't have good solutions for that dropout rate. What I can imagine is that there could be more patients randomized to receive local treatments that would probably refuse than those assigned to the standard treatment arms. So that's just my imagination, but let's just calculate or estimate, say 10% of dropout rate and just increase the numbers of enrollment.
So do you think some imbalance of the refusal proportion is occurred and across the treated arms?
I'm not sure, actually.
It is a very difficult question. So how do you think of it, so Dr. Nomura? So imbalance of the across the treatment.
Now this time points that I think the under 10% enroll.
Also difference. Also difference across between the proportion of the refusal patient with the same similar to the over the
almost patient wanted the local treatments. So this standpoint, so that very difficult to get this consent. That's the time. But initially, so the patients and we don't know the future response. So that also get easy to consent.
Okay, so Dr. Matsuda, so there are some imbalance will be occurred. So
yes, if the local treatment is only surgery, those patients will drop. But in this case, we can also provide a CRT. So probably we can estimate the same dropout rate.
Yeah. So we can choose the radiotherapy instead of the surgery. So it is less the harmful for the patient, and the patient so easy to accept for the local therapy. Yeah. Thank you for the good point. Okay. So already there's so many discussion point was discussed. Okay.
Can I ask about the new treatment, the adjuvant IO part? So do you want to define whether it is mandatory to give the adjuvant IO or just optional? If it is optional, it would also cause some.
So it's just a great point. So for me, so in my consideration, so adjuvant IO will be done. So without the chemotherapy. So if we started for example chemo-pembro and followed by local therapy, and after local therapy we continue only with some pembrolizumab because long relative systemic controls achieved by the ICI the pembro, and the chemotherapy 5FU and cisplatin will be sometimes harmful for and increase the toxicity after surgery. But not increasing the toxicity was provided the adjuvant IO. Maybe in Japan, so we can continue the monotherapy with a reimburse. And so I think that scientifically needed and is one of the issue, and another issue is we can do the IO with the reimbursed or not. Okay, so in the how is the Taiwan situation? No additional IO.
No, I don't think so. According to our reimbursement policy, now we cannot give the.
Do you think that additional adjuvant IO is needed for such kind of situation? If the reimbursement is allowed to use that.
Let alone the reimbursement issues, and for patients who show no progression to induction immunochemotherapies following local treatment, I would definitely continue some sort of systemic therapy following local treatments. Just let alone the reimbursement issues. But if we need to consider reimbursement, we cannot give the adjuvant IO in Taiwan.
Okay. So how is the Korean situation?
Yes, it's the same to Taiwan situation. And I agree with Dr. Shu's opinion that even after the local treatment, I prefer continuation of some kind of systemic treatment, but that might not be covered by the insurance.
So even with chemotherapy alone, so without the ICI?
Yeah, in the case, yeah, without ICI, nowadays the Korean government does not much care on the cytose chemo because it's cheap. So
yeah.
So cytose chemo, yeah, it will be available, but adding IO is not easy to be covered by the insurance.
So how about the Chinese situation, right?
In China, the adjuvant IO for those stage 4 patients are all covered by insurance. So, but you must consider about the clinical trial for every region. So maybe add adjuvant IO or decided by PI. That's
best available treatment.
Yes, that's more better for that.
And so of course, the country will be certified the factor. So it should be okay.
Because I should raise a question about the chemotherapy with local therapy, because it's very heterogeneous. Once the patient has the response, we continue the therapy. It's no problem. But sometimes in the disease progression, it needs local therapy to treat the local problem. So in this study, if it is possible to cross over or to allow the patient, if the continuous needed, or the patient requirement based on the condition to allow the local treatment.
Yeah, so I think so. If the patient local progressive diseases, and the need for the additional local therapy, we should allow the local therapy, even the standard of care treatment. So it is we usually do that clinical practice. Yes, I think so. Of course, some patient so-called crossover treatment was done after the progression of the standard of care. Yeah, but it does. Yeah, I cannot deny this option. Yeah. Okay. Any other comment and question for that? Also, Professor Takeuchi.
Yes, thank you very much for a very wonderful discussion. As I told you in the pre-meeting yesterday, I have another clinical question for patient with induced oligometastasis. For those induced oligometastasis, after remarkable response to the systemic therapy, that was originally polymetastatic, but changed to the induced oligometastasis. Those patients might be enrolled for this study. So can we add those patients with this designed study to improve the patient enrollment? Yes.
Okay. Thank you for that. So great point. So now we set the eligible patient along with the MESC4 and the synchronous one organ, one lesion, and the metachronous one organ, two lesion, two liver metastasis. So the Professor Takeuchi mentioned of that in the plan A. So would you prefer or acceptable for the enrollment? So for example, the 3 lesion liver metastasis patient or not? Agree or disagree? So please. or neutral.
So may I ask? Before I answer? To my understanding, the Professor Takeuchi's question is that whether we can include the induced oligometastasis. If that is the case, it's a different things than changing this definition. So we start from the more multiple metastasis patients, and then finally, if those patients enter this criteria, those patients might be eligible to the this randomization. Is that correct? So we can stay in touch with these definitions, oligometastasis, and then, yeah. So I just want to
Yeah, I
clarify.
understand that. So Professor Taki, so definition of the oligometastasis is making a consensus in the session 2. The curative the patient have a metastasis with a curative intent. So at the point, and then the relative wider indication would be allowed. So maybe that's everything that's induced the oligo with the candidate for this trial. It is not consideration from the Dr. Takeuchi. So I ask you slightly wider indication with consensus. The 3 region is a fair agreement for the OMESC4 trial. And 3 metastasis for the lung region. That depends on the location. Already Professor Kim mentioned about that.
So I agree with Professor Takeuchi's concept is that it's not bad for this trial to add more patients, and it can answer some questions whether 3 lesions is also included in the oligometastasis, because this time 2 lesions and 3 lesions are very controversial, but finally 2 lesions consensus. But if after this clinical trial we have some 3 lesions, we finally check the results. If the same, the consensus can be updated to 3. If it is separated, of course, we will go back to this consensus to lesions more better. Yeah.
Okay, so any other comment? So the Professor Kim, so you mentioned about some patient with the 3 region have the candidate for the resection, but it does depend on the location and the situation. And OMESC5 trial said there MDT conference and the review of external review of the oligometastasis. If there's a patient who before the enrollment consulted the MDT team with a 3 region patient. So some patient is omitted, MDT, and some patient can be enrolled. So in that kind of the situation, is this possible to enrollment for the 3 region patient?
Still a great question, but actually, for the clinical trial, we need to follow the result of OMESC3 or 4, OMESC4. In that case, we need to establish a strict criteria, because there might be many bias if we allow 3 and then 4 like that, and also the location might be matter. So I think simpler one is the best one. Yeah.
Yeah. So simplify is more important, and so yeah, it is so the generalize after that of the result will be so important component there. Professor Lee, so how do you think about the inclusion to the this trial, metachronolosis, for example, the 3 region in the lung or 3 region on the liver? It is acceptable for that?
Yeah. As my opinion, I think the agreement with most of us is the most important. Actually, to my point of view, if the lesion auto resectable, there is no matter 3 or 4, 3 or 2, the clinical outcome will not so different. but we were the most precise, most safely to make our result more comfortable, more confident. Maybe the single one is the best. So the number, I think the number does not matter so much, but it depends on the consensus of our experts. Asthma, the 2 or 3 not so different. As if it is from the surgeon point of view, you just resect it and no other lesion. 2 or 3 does not matter. But the most important 1 or 2 or 3. 1 is I think the best. Yeah.
Okay.
Yeah. So after this recommendation from Takeuchi, that we can imagine in the future if we add the results, the survival rate is maybe very beautiful. 1, 2, 3. We can add more evidences for that to answer the questions to the world. Yes.
Subgroup analysis will be some provide the indication. Okay. But so in the morning session, the 3 liver metastasis is not candidate for the resection. I remember. So I forgot it. So who said that this opinion? What is it? So the discrepancy. So in such cases, the oligometastasis plus alpha is our clinical question. And so subjective is a wider indication about that. So yeah. So how do you meta-rationalize? So Professor Su, so how do you think about it?
I agree with the comments of Professor Lund very much, but I also agree with Professor Kim's comment very much. And I think there's a pros and cons for either approach, whether we stick the strict criteria or we expand the criteria, inclusion criteria to really attack the questions the patients who have their disease beyond the strict criteria, but still within the European guideline. That is an area that I think is controversy really exists. So, and I don't, I think probably I will change my mind in next minutes. But the other thing I'm considering, but I don't have a clear answer for that, is that to respond to Professor Takeuchi's the proposals to focusing on those who have induced oligometastasis.
Yeah.
We probably can think about special trial designs to enroll those patients into this study and different from this primary cohorts, and also do some randomization in that cohort to see whether adding will really benefit their survival. Let's do randomization, or we still can, if not go for a randomization, we can still go for a single arm study to show those patients also have very good survival rate, probably similar to those who present with primary oligometastasis. So I'm just thinking whether we can just incorporate that kind of approach in this study.
Yeah. So how do you think about Professor Hong?
Yeah, I agree with Dr. Shi's opinion that there are pros and cons on the limited inclusion or extended inclusion. So when we use the extended inclusion, that we can get answer from for example, for liver metastasis with 3 regions. So my gut feeling is that that kind of patient does not get benefit from local treatment. But our trial, if our trial have include the liver metastasis more than 3, not more than 3, then we can the result will answer that my gut feeling is right or not. And for the the induced oligometastasis, I think we need a different trial for answer the question. So it's a little different patient population. So, and that will be also very good clinical question. So I have many the induced oligometastasis patient, even especially in lung, and they get a great benefit with the local treatment and especially the surgery. So I think that kind of scheme can be applied to ESCC too.
Yeah. So I think so. My opinion is similar for the UN. So wider so indication. There's so strict so indication for the omega-4 plus alpha and the induced oligometastasis will be so evaluated inside with the omega-5 trial. And so if the patient after the systemic therapy before randomization, maybe also be the MDT team review the resectability, and then and arrow for that, then there's randomized part so this orders the patient who is not the candidate for the resection is so omitted from the randomization, I think. So okay, so sorry to sharing. So the time has gone so immediately. And this another plan B or plan C. Do you have any comment for the plan B or plan C? Maybe the plan A is a consensus for the further verification. Okay, so no one. So raise your hands of plan B and the plan C. Okay, so finally, I would like to explain about the structure of the omega-5. We have a JCO in the domestic clinical trial group. And we conducted international trials. Also the Atlas headquarters and the National Cancer Center we have. And already we have the summer conducted the clinical trials with Japan and Korea and with Taiwan and the Asian countries. So we conducted firstly the JCOG in the omega-5, and then we need a budget, and if we can get budget, we will expand this trial to the using Atlas platform. So just Atlas J group was established right now, and Sama investigator is already included as a core member of the Atlas GI group. Okay. Okay, so that's time to close the session. So I think it be a very constructive discussion can be done for the further clinical trial, and maybe the next year we will do the kickoff meeting of the omega-5 trials next East Asian conference. I hope, if possible. Okay, thank you for your important comment and the discussion. Thank you.
Okay. Thank you again for especially the long meeting since last evening till now. Especially, I thank Professor Kato and Professor Takuchi to arrange such. Yesterday we have a hot discussion, and especially the hospitality of the dinner. I think although we study the science, but fellowship is most important to establish the science. This is the third year of a this meeting of the East Asian Esophageal Forum. I think from the first step, we have to make a big difference. 4 decades ago, we have from the effort and or the team has started very important. But for 3 years to come, we just not only for experience exchange, we have stepped into more cross cooperation and more consensus in the further clinical trial. I think we are moving forward more brilliant future. We can see the very successful outcome for years to come to change all the treatment landscape for the world. I think thank you all of your participation, especially from years we can see such as the Osbeck study. You take years to make all the consensus. Dr. Nomura has set up all the, it's a very difficult and time-consuming task and handle over those difficulties. We can see, even though such difficulty, there is still gray zone about the consensus, about the agreement. So the meeting face to face is very important. So from the discussion of yesterday and today, I think all of the controversial and the difficult part has been solved. We have to move forward. After this, we can move forward more smoothly in the future. So thank you to all of you for your participation, especially Professor Kato, Professor Dr. Shi, from all of the leadership, strong leadership. I think take an example for the, we have to follow the cross trial treatment worldwide about the NCCN guideline. But as we know, adenocarcinoma and the squamous, the difference exists. So the first trial in Europe has shown the difference from the cross trial. But so in the same situation, the agent should have different, not applied universally to the study result from the Western part. So we must solve by ourselves. So we have been moving forward a big step. We hope in the future we will move forward more smoothly in the future. So Osmex study, I think we are very happy to conduct all this trial. I think in the future, next year or next year to come, we are more new outcome and new result move forward. So thank you and for the participation, and hope to see you in the near future. Thank you.
Okay, thank you for the participation there. So, so the third, the East Asian, esophageal cancer forum is finished. Thank you for the hot. So of course, outside is extremely hot today. So over the 30 degrees, yeah, like so our hot discussion. So please take care and safe trip to the home. Thank you so much.